Good morning. I will call to order this meeting of the Healthcare Affordability Advisory Committee meeting. Thank you all for being here on this Monday morning. So this meeting is coming to order, and please note that this meeting is being recorded. I will first ask for a roll call, please.
Good morning. I notice we have some virtual attendees, so make sure when your name is called to come off mute and let us know you are joining us today. Joan Allen.
Present.
Barry Arbuckle.
Present.
Eliza Arjoyan.
Present.
Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty.
Present. Oops. Present.
Adam Donnery.
Present.
Parker Duncan Diaz.
Good morning.
Hector Flores. Stacy Hiratas.
Present.
David Joyner.
Present.
Travis Lakey.
Present.
Tam Ma. Present. Carolyn Nava. Mike O'Day. Mike, I think I see you attending virtually. If you can unmute and let us know you are there. We'll check in a moment.
Yes.
Uh-huh.
I'm here. Thank you.
Good, thank you. Janice O'Malley.
Present.
Mariel Riazza.
Oh, sorry, it's Mariel Reataza, present. Thank you.
I'm sorry about that. Thank you. Samana Reddy.
Present.
Yolanda Richardson. Christina Rodriguez. Karen Savage Sangwan. Andrew C.
Present.
Stephen Shortell. Sarah Sorokin. Ken Stewart.
Present. Here.
Suzanne Usage.
Present.
Renee Williams. All right, that concludes roll call.
Thank you. So with that, we have a record of who is in attendance and we have a quorum. I'd also like to note that we are joined by Sandra Hernandez, our attending board member, who's with us today online. And as always, we have a board member present to listen to the presentations and discussions and help us convey to the board the feedback that you all are giving to us. Before we review today's agenda, I'd like to note that we have extended the deadline for OCA's 2025 Advisory Committee member solicitation process for a physician's perspective. So many of you whose terms are up have reapplied. We had other applications. The board reviewed those, and then we held the process open to allow for additional physicians. So that closed on June 5th, 2025, and at our next board meeting in July, we will present the recommended advisory committee member slate to the OCA board for review and approval. On to today's agenda. So after our executive updates, Vishal will give a brief update on measuring hospital spending. We're joined by Brian Kearns, OCA's Assistant Chief Counsel, who will present updates on the Cost and Market Impact Review Program. After breaking for lunch, we have presentations by Margaretta Brandt and Debbie Lindis about the behavioral health definition and benchmark. And last but very much not least, we'll have a presentation by Vishal, CJ Howard, and Andrew Farrer. They will end the meeting by briefing the committee on our baseline report that was published earlier this month. So moving on to executive updates, I'd like to wish folks a happy Pride Month. We had a good contingent of California Health and Human Services Agency folks marching in the parade yesterday, and I'm proud to work in California for an agency that truly values all Californians and celebrates our diversity and works toward equity. As I noted, we will be presenting our OCA baseline report, and I want to take a moment to acknowledge all that went into this. We learned from other states about the data collection process. We dug into the available data, so appreciation to all of those who shared potential data sources with us. We devised our data submission guide, which was a very detail-oriented process. We got guidance from the board and the advisory committee and many, many stakeholders about what was important to capture with the data. We also worked extensively with the health plans who were submitting the data. So thank you to all of you who gave us feedback about how we should structure the data submission process and specifications. Those plans that tested submissions of the data helped to validate what you were submitting. So the plans, again, tested with us, and all of the plans submitted the required data. I'm also very proud of the work that our data team, all that our data team put into this process. It's not a simple task to build a whole new methodology, come up with the data specifications for the system to collect that data and figure out what's meaningful. So kudos to Vishal, to CJ, to Andrew, and to Andrew's wonderful team of folks. As would be expected, we have had some challenges and have some reflection about that. It's very complicated to capture data specifically for dual eligibles. Do you put them in with Medi-Cal? Do you put them in with Medicare? Do you have them separately? How are different dual eligibles provided with care? So we've had some meaty discussions, including with our colleagues at DHCS, about that. Also, the many complicated Medi-Cal spending streams and the non-Medi-Cal programs administered by DHCS. So you'll hear from the team about some of the decisions that we made about sort of where to put some of the data and some thinking about how to continue to think through that and unwind some or restructure that as we move forward. So we very much look forward to your feedback about suggestions for how to make the data as meaningful as possible. So look forward to your input. And we will continue to iterate as we learn. And I think this is a very solid first product. So kudos and thanks to all of those who contributed. We had initially, as HCI, planned to move from this building over to the Maley office building, and that move has been canceled. So we will remain here at 2020 West El Camino, and so our ongoing board and advisory committee meetings will be here moving forward. It's June, and so top of mind for many of us, of course, is the state budget. So yesterday, June 15th, was the deadline for the legislature to pass a budget. So after the governor's release of the May revision on May 14th, on Friday, both the Assembly and the Senate voted on Senate Bill 101, which is the legislature's is their budget. However, it is a two-party agreement between the Assembly and the Senate, and so there are ongoing discussions between the administration and the legislature about a final budget for the fiscal year that starts on July 1st. In terms, and I think folks are certainly tracking the fact that this May revision was very substantially different from the January budget because of so much federal uncertainty, because some expenditures or programs were more than originally anticipated. There's a $12 billion deficit projected as of the May revision, so a number of painful cuts were proposed. On the HCI side, there are budget change proposals to administer the BH Connect, the behavioral health waiver negotiated by DHCS with input from HCI about the behavioral health workforce component. So there's up to $1.9 billion available for HCI to invest in behavioral health workforce over the next 5 years. So we're very excited about the opportunity to do this work supporting the whole range of behavioral health practitioners, from peer support specialists all the way up to psychiatrists. So we're getting ready to launch our first two BH Connect programs, which will be a loan repayment program, as well as a GME program, a graduate medical education program supporting psychiatry residencies starting very shortly this summer. The May revision also proposes requiring that PBMs, that pharmacy benefit managers, be licensed by the Department of Managed Healthcare and that they provide data to HCI's HPD. Our Healthcare Payments Data Program, or California's All-Payer Claims Database, would receive this data from PBMs, and we would receive positions and funding to support this enhanced oversight of PBMs to gain a better understanding of costs and help improve the affordability of drugs for all Californians, something we're certainly very focused on and which Vishal will take a fair amount of time today in his executive updates to talk about what we know about prescription drug costs and what we're doing to address it in California. But we know PBMs are an important component that we don't know enough about and need additional transparency and oversight. Additionally, the May revision proposes expanding the authority of the CalRx program to partner with brand name drug manufacturers. So initially as adopted, the CalRx program focused on generic drugs. This change would give the state more tools to respond to supply chain disruptions, market manipulation, and other restrictions that can threaten access to essential medications, including those for reproductive health. The CalRx program is also proposed to have $5 million available to respond to emergent pharmaceutical health needs. That was most of what I wanted to cover in my executive updates. We're also pleased that the HPD, the Healthcare Payments Data Program's collection of non-claims payment data is moving forward. Again, that was a methodology developed jointly between OCA and our data teams here at HCI about how to collect that non-claims data. So very important to us, and actually the model that we adopted that we developed has been adopted nationally in terms of how to collect non-claims payments. So this approach has been adopted in regulations and again adopted nationally, and we will be working with health plans to prepare for the testing beginning in September of 2025 for collecting that non-claims based payment. And with that, I will turn it over to Vishal.
Thank you, Director. So I'll be going over some articles from Health Affairs, and then I'll also do a presentation on how OCA is approaching, and the broader department, HCI, is approaching its work on pharmaceuticals and affordability. The first article that I'm sharing is about hospital capital expenditures. So this Health Affairs article found that hospitals investing more in capital gain market share and raise prices, whereas hospitals investing relatively less in capital lost market share and increased their prices less. The pattern that the authors noted shows that even in the absence of mergers and acquisitions, markets can consolidate as demand shifts to high-priced hospitals. So what they did is use a combination of HCRIS, or Health Cost Report Information System reports, and commercial claims data from the Healthcare Cost Institute, or HCCI. They explored the association between hospital capital expenditures, prices, and shifts in market share between the years 2010 and 2019. The researchers found that as hospitals increased capital expenditures, for example, whether it's through increasing capacity, adding service line, or improving their amenities, this supported their entry into adjacent geographic markets that led to shifts in patient flow towards those hospitals that invested heavily and away from rivals that invested less. This shift in demand translated into large price increases at expanding hospitals, thus positioning higher price hospitals for future expansion. Over time, these market dynamics contribute to a higher concentration of market shares and higher prices, both at investing hospitals and market-wide. So this slide shows these hospital market dynamics, which they describe as a positive feedback loop between hospital prices and capital expenditures. So the first kind of step in this positive feedback loop is that profitable higher price hospitals invest capital relatively more than less profitable lower price hospitals. In turn, these capital investments, as I mentioned earlier, facilitate increased capacity, service line, and market expansions that shift patient flows to the investing hospitals. The third kind of prong in their positive feedback loop pertains to changes in volume of services delivered by investing hospitals, enhancing their bargaining power in negotiation with payers. This enhanced bargaining power leads to larger price increases for hospitals with larger capital. And I'll go on to the next article, which pertains to the Rhode Island affordability standards. So this piece examined evaluated the financial impact of Rhode Island's strategy to curb hospital prices and its effect on enrollee premiums and hospital margins in the commercial market. Beginning in 2010, Rhode Island capped hospital price growth in its fully insured commercial market as part of a regulatory package of affordability standards passed by the legislature. So these standards included policies to regulate prices, including inflation caps and diagnostic-based payments on contracts between commercial insurers and hospitals and clinics. They also included policies to increase investment in primary care. So the authors used a few data sources for their analysis. One was the earlier data source I mentioned, the HCCI, or Healthcare Cost Institute hospital price data, CMS hospital cost reports, and then MEPS, or medical expenditure panel survey data. They found that across the fully insured and self-insured market, hospital prices dropped by 9.1% on average between 2010 and 2022 relative to the trends observed in comparison states. And then the second observation they had was that fully insured premiums saw an average annual $449 reduction in premiums. In aggregate, the authors estimated that the Rhode Island affordability standards included a reduction of $87.7 million in annual premium and out-of-pocket spending for the fully insured market, an increase of $30.7 million in annual spending for the self-insured market, and a reduction of $158.3 million in annual hospital commercial revenue. The authors conclude that evidence from their study suggests that the affordability standards reduced hospital prices and resulted in lower insurance premiums and out-of-pocket spending in Rhode Island's fully insured market segment. However, premium reductions were not observed in Rhode Island's self-insured market, and they suggest greater transparency and oversight may be required for commercial rate regulations to benefit employers and members in the self-insured market. So I want to move on to the next item in my update, which is a correction we've made to the payment to cost ratio coding for the way OCA analyzed the commercial to Medicare payment to cost ratio. This, as you may recall, this feature we use to identify high cost hospitals. We observed a discrepancy between outputs in terms of measure calculations that were used during the initial analysis, which used Python code. It didn't consistently account for all 75 cost centers. It included 74. The missing one was therapeutic radiology, which was not consistently included in the original Python code. So in late May, OCA staff and consultants met to confirm the initial oversight. Upon recalculating the values, OCA found that the set of hospitals deemed high cost did not change. In other words, there is no change in the hospitals that meet the criteria from the board's April action, nor do the values impact the adjusted sector target values. We've updated the publicly available data set. We've reached out to the 7 hospitals that met the board definition for high cost in April. In addition, OCA updated the publicly available hospital level data set on its website, which could be found on our data and reports section. In the appendix to these slides, we've summarized the differences between the previously reported and updated payment to cost ratio calculations. I do want to pause here just in case we have any questions, because the next section I'm going to cover is pretty extensive.
Travis Lakey, thank you.
I did have a question on the capital expenditures, because a lot of us are doing seismic projects. How is OCA intending to use that data?
Data just generally about seismic expansions?
Yeah, I mean, obviously, debt service increases our expenditures quite a bit. So if we miss targets, is that going to be factored in?
We're going to start a public process on reasonable factors for exceeding the target. So the statute has these set of criteria for factors that may cause an entity to exceed the target. Some of these include new state mandates, catastrophic events, high cost drugs. So that'll be part of the public discussion on how OCA considers that. As far as, it wouldn't impact the target setting, but it could be part of the discussion on the back end.
Carmen Comsty.
I had a question about the Health Affairs article about Rhode Island. With one of their conclusions or findings that there was a decrease in premiums and out-of-pocket spending, I would be curious to see, what data they were able to collect on that, because I think that's a really important thing that we should be able to do as we're implementing the price controls to see, how it actually impacts, patients and consumers. So I think it would be interesting to know, what they looked at in order to make those findings, if we know.
Yeah, thanks, Carmen. That's a question that comes up quite a bit. So, with the medical loss ratio requirements on plans, like the intent is that if entities comply with the target, that it's going to lower medical spending in terms of the growth rates. So that should in turn result in, when health plans go to DMHC for rate review, that they're going to have a lower medical trend, and it should result in lower premiums and out-of-pocket spending. So that's something we're going to monitor over time, and we could do that through the publicly available rate data that DMHC collects, as well as through other data sets. Like in this particular study, they use MEPS data, but we could consider other data sources as well.
Barry Arbuckle.
And I think to follow on that question, it would be interesting to compare the Rhode Island experience with the Massachusetts experience, which we're modeled heavily after, because before the Health Policy Commission in Massachusetts, hospital price increases were averaging in a 10-year period 6 to 9% a year, and premium increases were going up 2 to 3 times both CPI and wage. In the years since, hospital price increases have gone up 3.4 to 4% a year on average, but premiums have gone up 2 times inflation and more than 2 times wage growth. So there's a missing gap somewhere between containing hospital prices and then actually translating down into premium decreases. And that might be shown on a slide later today that showed some pretty impressive health plan profits.
Yeah, Suzanne Uzaj.
Thank you for the research. Same topic or same article. I was curious if there's any cautionary tale or watch out for the fully insured decrease, but self-insured increase, and if there's something to monitor on cost shifting or something that could have been occurring during that time period, because it is a pretty wide gap.
Yeah, they have a few hypotheses on that. They noted that self-insured premiums are difficult to quantify because of the lack of data in the state. So to be able to calculate that premium equivalent, as you know, self-insured employers don't have to report to the state regulator. They also noted competitive forces for self-insured plans may be attenuated because premiums may not always reflect the cost. They kind of described it as imperfect competition that the self-insured employers may be wanting to differentiate themselves on networks, benefits, and customer service. So it doesn't always kind of have that exact match with kind of medical trend in terms of what it costs to provide care. They also noted there could be the effects on the self-insured could be diminished because of fee increases that were observed in the self-insured market segment. They attributed this to third-party administrators and administrative services only providers, may be able to increase fees, and self-insured employers have limited transparency on those fees. So they provided a few hypotheses on that. And they did call for greater, transparency and data reporting on self-insured, but as you know, there's limitations on that in terms of what states can do on that front. So I'll cover a few topics on pharmaceuticals and affordability. I'll start by giving some background on pharmaceutical costs and their overall impact on spending. So this chart, the title slide is Pharmaceuticals are a Cost Driver. The figure shows rapid growth in retail prescription costs over the last few decades. Retail prescription drugs do not include drugs that are physician administered in hospitals, physician offices, or outpatient centers. Spending on prescription drugs has increased since 1960, with growth accelerating in the 1990s. Adjusting for inflation, retail prescription drug spending per capita in the U.S. increased from $100 in 1960 to $1,147 in 2021. Some factors for this growth include unit prices, changes in unit prices, changes in utilization patterns, especially with the market entry of new high-cost drugs. Some examples, as many of you know, are GLP-1s and very expensive cell and gene therapies. Some growth is also caused by excessive profit-seeking and anti-competitive behavior across different actors in the prescription drug market. And then going on to the next slide. So at the same time that prescription drugs are a cost driver, they can also serve as a moderator of costs because they help people manage the conditions they have, such as patients that take selective serotonin reuptake inhibitors or SSRIs for treating depression. Prescription drugs can also be used to mitigate the risk of developing conditions such as statins to lower cholesterol and reduce the risk of heart disease. However, the high cost of certain drugs pose a barrier to medication adherence. About 3 in 10 adults, the bar chart on the left indicates that about 3 in 10 adults report not taking their medications as prescribed at some point in the year because of cost. There's a few other statistics, about 1 in 5 having not filled a prescription or took an over-the-counter drug instead. And about 12% say they cut pills in half or skip a dose because of cost. So shifting to the figure on the right, poor medication adherence leads to worse health outcomes, but also contributes to increased costs for that patient and the overall health system. Some have estimated that poor medication adherence leads to additional costs of thousands of dollars per member per year. And I'll go on to the next slide. You know, as we've discussed at our board and AC meetings, there's a complex distribution system for pharmaceuticals. There's several actors between the production of a drug and the drug getting to a patient. Manufacturers sell drugs to pharmacies through contracts, with drug wholesalers, and pharmacies in turn dispense drugs to the patient. When pharmacies do so, they run the claim through an administrative process, which involves pharmacy benefit managers. These entities tell the pharmacies how much the patient should pay for the prescription, and they collect and pass through reimbursement to the pharmacy from health plans. The 5 entities shown here, manufacturers, wholesalers, pharmacies, PBMs, and third-party payers or health plans, each play a role along the distribution chain. Of note, the lack of transparency in multiple steps in the system means that there are many opportunities for markups and misaligned incentives that lead to increases in overall drug costs. For example, PBMs decide what drugs are prioritized on a health plan's formulary in exchange for price concessions or rebates from manufacturers. PBMs argue that this leads to overall lower costs, but others argue that these rebates lead to preferential selection of higher cost drugs so that more rebates are retained by the PBM or the health plan. And then taking us to our next slide. So this is a very busy slide, but I'll kind of break it out into more digestible pieces. So what increases these costs? First, there's research and development costs. It typically takes 12 years to move from preclinical testing to final approval. There's some estimates of $3 billion to develop a new drug, with only 10 to 20% of drugs tested being successful in reaching market. While these R&D costs are staggering, some studies have found no correlation between how much drug companies spend and the drug's price. There's rebates, as I just discussed. There's also a lack of transparency in contracts across the system, making it difficult to see where the money flows. There's also spread pricing, where a PBM reimburses a pharmacy less than what the PBM gets from the health plan for a drug. There's also substantial concentration with 3 PBMs and 3 wholesalers dominating the market. So as the figure shows, there's substantial vertical integration between insurers, PBMs, group purchasing organizations, manufacturers, and pharmacies. Some have even described PBMs as profit centers for vertically integrated health plans. On the pharmaceutical manufacturer side, there are also practices that have anti-competitive effects, such as product hopping, which, as some of you know, involve minimal changes to a drug. This could be changing a tablet to a capsule, or combination products, or very small improvements on insulin pens, and then getting doctors to switch patients to the updated version. There's patent thickets, which is essentially multiple patents on drugs to deter competition. Rebate walls and bundling, where certain drugs that are covered on a PBM formulary require the health plan to exclusively cover that product, or bundle it with other products in order to get those savings. There's also, this involves generic companies too. Some are accepting pay for delay deals where, they keep their WAC prices higher than they should be. And then lastly, as I mentioned earlier, there's increased utilization and introduction of new high-cost drugs, which lead to increased spending. Some employers are saying GLP-1s are taking up 2% of their pharmacy benefit alone. Cell and gene therapies may cost between $2.5 to $5 million per application, because these have to be tailored to specific individuals. So I'll take us to our next slide, which is what HCI as a department is doing to respond to some of these issues. On the next slide, we've included some references to pharmaceuticals in the OCA statute. So in the legislative intent language, there's language pertaining to analyzing costs and quality trends in the pharmaceutical sector, studying how drug prices and pharmaceutical market failures impact affordability, informing public policies to improve competition and lower costs. In OCA's definitions, pharmacy costs are counted in our THCE, or total healthcare expenditures measure. When we turn to cost driver analysis, the board will also discuss drivers in the pharmaceutical sector. Taking us to the next slide. So there's other references to for OCA to examine Senate Bill 17 data, which I'll discuss in a later slide, and healthcare payments data, or California's APCD in our analyses, and not to disclose any proprietary or confidential information in our reporting. And then going on to the last slide about references in the statute. Our cost and market impact review program also has regulations that require PBMs to file advance notice of material change transactions if they meet certain regulatory thresholds and circumstances. And then lastly, OCA has broad authority to conduct research on the healthcare market, which can include pharmaceutical companies or the pharmaceutical sector. And then taking us to our next slide. OCA itself is building analytical capacity for pharmaceutical policy research and analysis. We're building a small team to do this work. There's essentially two buckets of pharmaceutical policy work in OCA. The first is to support OCA in much of the work that you're already familiar with, which is studying trends and drivers, considering what types of drug costs may be a reasonable factor for exceeding the target, and so on. The other bucket of work on the right-hand side, general research and analysis, involves work to support other state efforts to improve drug access and affordability, such as the CalRx program. Some of this work will involve reviewing best practices in other states and how we can replicate those ideas here. And then also making policy recommendations in our reports. We're going to go over the baseline report today. Going forward, we'll have annual reports as well. And we could make policy recommendations to address anti-competitive behavior, promote greater transparency, and other tools or actions that could make drugs more affordable. And then going on to the next slide, which focuses on data. So I'll give you examples of the ones that are listed in the top set of bullets. And the second set of bullets, as the director mentioned in her remarks, there is a PBM reform proposal that's moving forward. If enacted in the budget, would add PBM data to the HPD, which will include drug cost and spending information, rebate information, PBM payments to PBM-owned pharmacies, counts of scripts, and then distribution channel information. Next slide. So I mentioned the CalRx program earlier. So this is a program that HCI administers, which focuses on state partnerships, resulting in the production, procurement, or distribution of generic drugs and making them available at low cost. So the focus of this program is to target areas where the U.S. healthcare system has failed to lower costs, even when a generic or biosimilar is available. Some of the examples of our initiatives are shown here with the CalRx biosimilar insulin initiative, a reproductive health stockpile, and a generic or over-the-counter naloxone product. Next slide. And then this is an elaboration of some of the earlier data bullet points that I mentioned earlier about how we're using data. So to support an equitable distribution strategy for CalRx insulins once they're available, HCI is using a combination of HPD data, American Community Service census data, and pharmacy location data from the Board of Pharmacy to create a visualization to map vulnerable populations by county, where there's higher prevalence of diabetes, by county and zip code, to inform our distribution strategy. So when these insulins are available, HCI would work with stakeholders in these areas to identify strategies to improve access. This can include alternative distribution methods, partnering with local organizations in the area, or implementing direct-to-consumer or mail order options for hard to reach or areas with more difficult access, such as rural areas. And on the next slide is our HCI's activities related to prescription drug cost transparency data reporting. So in 2019, SB 17 required prescription drug manufacturers to submit to HCI a 60-day advance notice of wholesale acquisition cost increases for drugs with a WAC increase, which is essentially the list price, an increase of 16% over 3 years, and HCI receives a reporting for if this were to occur. The second data reporting requirement relates to a 3-day advance notice of any new drugs that enter the market that exceed a Medicare Part D specialty drug threshold of $950 per month in 2024 per course of treatment, and additional information about about those new drugs. HCI has begun collecting this data, and the next slide shows that we've collected 7,500 reports to date. So in addition to collecting the data, we also posted on our website in an interactive visualization format for public use. One report for price increases is, or one example of a report is price increases cumulative from 2019 to current year. Another category of reports that we visualize is price increases during the current calendar year, and the third visualization pertains to new drugs introduced to the market. And I'll take us to our last slide, which pertains to how the HPD, or Healthcare Payments Data Program, will collect prescription drug data. So HCI has collected claims data on drug costs. We've done a fee-for-service drug cost report for the commercial market. There is some data that we've put out related to monthly median out-of-pocket costs for the 25 drugs with the highest out-of-pocket cost in the commercial market in 2021. As some of you know, there's state policies to limit copay caps of $250 per script for state-regulated health plans, and the findings that we report on our website are consistent with the impact of those state policies. And then later this year, we're going to begin collecting pharmacy rebate information from payers as part of our non-claims data collection effort. So I'll just cover one last slide before turning it back to the facilitator, which is our slide formatting. As many of you know, we've indicated by a blue areas where we're seeking advisory committee input. And I'll turn it back over to Jane to facilitate conversation.
Discussion. I'll start with Travis, then Andrew, then Simona.
I wanted to thank OCA for tracking pharmaceutical spending as a cost driver, because I know at my hospital it's up 11% from last year to this year, and we have no control over those expenses.
Yeah, I guess I would also applaud OCA for tackling this topic on. I mean, for me, pharmacy is pretty complicated, right? You have inpatient, you have clinic administered meds, and you have the retail. So kind of what we traditionally think of as kind of just outpatient pharmacy. Just want to encourage that, the view is holistic, especially you look at, on the inpatient and the clinic administered side. And also, to me, the cell and gene is a little bit of a boogeyman. It's kind of like all over the place, and there are a lot of adjunct services around it, right? Some of these things, require, chemotherapy, hospital stay, and so just be holistic in kind of how this thing is approached. But thank you for tackling it. It's very complicated.
Yeah, Andrew, could you elaborate on like the boogeyman comment?
Oh, well, some of them have like $4 million price tags to them, right? And there's a long pipeline of these cell and gene therapies that are going to hit the market, right? Right now, all of the oxygen is being sucked up by GLP-1s, and of course, there's a bunch of those hitting the market too. But the cell and gene stuff, it's pretty hard, right? Because they're cures, and they have big price tags attached to them, and they're not easy. I mean, a lot of them require, basically some chemotherapy up front, long hospital stays, and just there's a lot around those.
We'll do Samana and then Ken.
Yeah, thank you for this hugely important topic, and I don't envy decision makers like Andrew on how to deal with that level of cost. Just wanted to throw in another aspect, the way it ties into prior authorizations, but I'm finding there's no sense of responsibility from the PBMs on basic issues like we have one gentleman who's been out of his long-term insulin for 3 months now. The fact that he happens to have a life-threatening illness and is losing weight just allows, me to not think it's critical in the moment, but it's horrifying that what they've been doing is throwing prior auths as one after the other. We send it, they deny it, saying that's the wrong brand, but they don't tell you what options, right? I have a stack of paper this big that I gave to the family because as we went through this process, ultimately we discovered there's no communication between the PBM, the pharmacy, and now the nub of it is that all the brands they accept are not in stock. So you have to go through a prior authorization process to get what might be in stock. And then the pharmacy says, we have only 1 unit of that. So just, again, to give you the picture of how the time sink on this, there's the cost, but then there's also the access side that nobody takes responsibility for. Thank you.
Having run the DMHC Help Center for several years, I just have to make sure that you're referring those folks to the Help Center to appeal those denials, because that's outrageous. That should not be happening.
That's the level that we are next going to explore. So,
which I know isn't easy for patients to do, and it's critical. Thank you for flagging that.
Yeah, commenting on your overall cost in the beginning, I'm wondering at what point was advertising of medications approved? Because I believe our cost tripled when that happened. So I think that's a big part of it. But on the same light, I've known for a while it was suggested that the price of a car includes about $15,000 on average for marketing. And I'm just wondering if any attention has been paid to the component of the WAC or retail prices for advertising. Because 9 o'clock at night, all you see is advertisements. I never knew so many people had eczema and psoriasis in this country, but there must be 5 new medications out for that. And the other thing is on the PBM submission of data to the HPD, is that going to be subject to the GO-BAY limitations?
Yes, it will. So for folks who don't know, that's the Supreme Court case that limits. So it will continue to be the case that self-insured plans aren't required submitters. So that doesn't change the law. And Ken, as to marketing, I'm sure you know, I mean, there's limits to what states can do about a number of components of prescription drugs prices because of limits on interstate commerce. So we're certainly exploring doing what we can.
Katie and then Barry, I think. Okay. Oh, sorry. Barry, go ahead.
And it'll warm your heart even more, Ken, to know that of 200 nations in the world, only 2 allow direct-to-consumer advertising of drugs, us and New Zealand, so we're in good company. I too wanted to applaud the work that HCI is doing on tracking these pharmaceutical and drug cost increases. Under SB 17, I note that there's a requirement for HCI to be noticed of introduction of new drugs to the market. Do you also get a notice when a relatively new drug to the market, or any drug for that matter, has a new clinical utilization use, which can expand wildly the use of that drug? I mean, and sometimes the data that allows those new utilizations is not very robust. I'll give a quick example. Wegovy, which we've talked endlessly about, that category of drugs, currently is about $1,500 a month, so it easily qualify. Maybe it was submitted years ago, or if SB 17 was applicable. In the last couple of years, the drug manufacturer, as they tend to do, has found new applications for Wegovy, not just obesity, but cardiovascular risk. It was based upon one data point submitted to the FDA, which showed a 20% risk reduction of cardiovascular events with Wegovy. 20% sounds pretty impressive. What they didn't submit was the actual risk reduction, which is 1.5%, pretty meaningless. They also didn't submit what's called the numbers needed to treat. How many people needed to be treated with Wegovy for how long to avoid one adverse cardiovascular event? And in this application, it was 66 people for 3 years at a cost of $3.15 million to avoid one cardiovascular event. And it was approved by the FDA, and we're now getting requests for it now. So if there's any way to add new clinical applications for an existing drug, might be worth looking at as well.
Thanks very much, Barry. Anyone can correct me if I'm wrong. I do not believe that Senate Bill 17, which was passed in 2017, requires, if there's an expanded use of a particular drug, just to market and then with expansions. And then there's additional SB 17 reporting done by Department of Managed Healthcare, which is pretty robust to see drugs. So I think between, if we get this PBM piece and we're collecting the granular data, we're going to have a pretty good understanding of what's going on, and then we need to do a lot to address it.
Suzanne?
Just echoing everyone's sharing, thank you very much for folding this in. I did want to notate that obviously the pharmacy benefit managers are one avenue for drugs. There's of course then kind of like the buy and bill, usually a facility obtaining the drugs directly from a manufacturer and then calculating costs on top of that. I was wondering if that's also folded in or if that's already in some of the costs, because the hospitals might be submitting to the HPD. Like an infusion medication, the most common.
Yeah, that's probably folded into the billing that they do on the outpatient side for drugs. We are having some meetings with healthcare entities, including hospitals, to learn more about brown bagging, clear bagging, to kind of know what's the kind of general standard of practice and kind of what's a reasonable markup, and to kind of getting more information about kind of those billing and reimbursement practices.
Got it. Thank you. That'd be really interesting to kind of fold in alongside this, because I know at least on some situations that I see, the drugs might be available in both situations and the cost might be pretty dramatically different between the two. And so I don't know if that's, or a theory might be that whoever's acquiring the drug is helping set the price or taking some in between. And so then it might be interesting to compare the drugs through the method in which the actual end user is obtaining the medication, whether it's through their PBM on the insurance plan or through the medical side. on like J code, Q code drugs.
Thank you.
Joe?
Just a couple questions. Really appreciate all of this, and it's been a wonderful discussion. And first, do we have an estimate of when the rebate information will start to flow publicly?
I don't know that, Joan, but we're happy to check and follow up with you, unless you know the show.
I think it's beginning to just be collected because the non-claims regulation
Yeah, that's what I thought.
just recently became effective. So yeah, we could circle back.
Yes. So the collection of the non-claims data will start in September 2025, but I don't know when we'll have publicly available data to present.
Yeah, because I think that's going to be fascinating. And then I've been a little bit thinking, Andrew, on what you were saying about not only those incredibly high-priced drugs, excuse me, but also then the wraparound costs of that initial chemotherapy and the hospital stay. Do we have either any data from other states or any sort of ways of thinking about not just what is the actual cost of the drug, but what is the entire cost to the system of the wraparound services, particularly for those non-retail?
Yeah, what are the wraparound services? The ones that Andrew mentioned, or?
Yeah, so sometimes some of the drugs are so complicated that you'll have a hospital stay, right? So it's not just the drug, but kind of everything around it, and all the treatment. And then you get into the whole clinic administered meds thing, right? Where you could do it self, through outpatient, or it's being done in the clinic space. So you get the drug and the professional fee. Mm-hmm. So there are just a lot of services around it.
So you're talking like dispensing, professional visit fee, any facility fees, and okay.
For cell and gene, it gets pretty complicated. I think there's just a lot of variety around it, and some of it really does require long hospital stays associated with the treatment.
Yeah, that sounds more like an ad hoc analysis, like on an episode of treatment. That's would probably require more like something like HPD data.
Yeah, it'd just be a really interesting. It's something I really hadn't thought about until you started listing those out, and I've been going through in my mind of like, okay, and there's labs, and there's the facility fee, and there's all these things, and so even just the list, even just that whack can really then also balloon with the rest of those services.
All right. We have 4 committee members attending virtually today. So looking virtual, Marielle, I see your hand raised. So we'll go to Marielle and then Simana.
Okay, let me see. Can you hear me?
We can. Thank you.
Okay, great. Thank you. First of all, I want to thank you for compiling these additional data sources. I want to echo everyone's comments that this is such an incredible and tremendous task, and I thank you for really considering our comments and also just expanding the connections that all of these costs have. So I meant to join in person, but I am, under curfew in downtown LA, and I didn't want to take any chances in case I got pulled over or something. So my first question, just kind of thinking about everything is there any way to track or collect data on which prescriptions from providers are declined? There are some cases where out of pocket, if it's available, it might, if it's available, over the counter or some other means, it's less expensive. And we know that, more and more people are opting out of some of these prescriptions because of the costs. I don't need to clarify more on that. I have 2 more questions. Just want to know, should I pause now?
Sure.
Or should I keep going with my questions? Okay.
You could keep going.
Okay. Sorry, I think there's a bit of a delay. And then, I also have a follow-up question, right? Because with a lot of people trying to access generics as much as possible. I know that there is some allowed variance from the, from the purity or the, the manufacturing of the generics and the name brand themselves. All I'm thinking about, and I don't know this data, and I'm wondering if anyone else does or if y'all can comment on this, but right, if we have more people who are opting for generics and is there any kind of correlation, or do we know if there are any more indications of adverse effects? And the last question that I have is, I think that this is really, really important information. I think, all of us on this committee and on the board, and of course at HCI, can attest that it takes an incredible amount of knowledge and experience and expertise really to understand this data. But I think we should also capture the moment that a lot of people are making these connections, right? Not just us here in this meeting, but all throughout California. And I wonder if there is a way to, present this or organize this for community such that it's in plain language so that everybody can really understand this, because, there is a desire for a lot of people to engage on healthcare policy, but we all know it's very tedious. So that's my last question. And again, thank you so much.
Thanks, Marielle. For the first question, the HPD doesn't collect denied claims. It's really the adjudicated claims. So we wouldn't have line of sight into those scripts that get denied. I think in that respect, we'd probably turn more to the literature and kind of see what's where researchers are doing in that space. And then I think the second question, if I understand it correctly, you're asking about kind of our generics, equivalent to the branded product. And I think so. At least there's no association between generic use and adverse effects. These are FDA approved products that are safe and high quality. Is that the question you were asking?
No, can I clarify my question then? No. So for instance, and maybe RFK will get me on this, but I have ADHD, or I manage ADHD, and something that a lot of folks are discussing are the generics right now working or as effective as some of the brand name versions of the drugs. And so, this is not a comment on, are they safe? I do believe generics are safe, but on that thread, and I recognize that medications for ADHD is a little bit more complicated and controlled. I'm wondering, right, is this happening across the board where, people are experiencing, maybe new adverse effects? So for instance, right, you have a manufacturer who's maybe they're manufacturing the generic version, and for whatever reason, another manufacturer makes it, and while they're supposed to be, equivalent, there can be some differences, including some differences in adverse effects. So, that's really where that's coming from. I don't know, again, if anyone's tracking that data, but just wanted to know if you had any insight on that, or if that's something that can also be looked at.
OCA, wouldn't know. It doesn't have an answer to that. I think we're aware of reporting to the federal government about adverse drug-related events. And then the other question you had about making things more more digestible for the average consumer. We are aware that a lot of the conversations we have here are very wonky and in the weeds. That's something OCA is thinking about in terms of what could we do in terms of infographics or some other kind of way to make the top lines of our findings more easily understood by consumers.
Thank you. I appreciate that, because I think that's what's really, as far as consumers or regular everyday people who don't speak this jargon, right? They want to engage, they just can't. So I really appreciate, that consideration, and I hope we move forward on that. Thank you.
Thank you. Any further discussion from the committee? Yeah, Simona?
Just briefly underscoring that value of the statistical analyses like number to treat. I really appreciate that Barry brought that up. And then back to the digestibility of information idea. Clinicians need that. And then the support for the time, because now we're hearing that GLP-1s have massive adherence issues, right? So I'm thinking, oh my goodness, not only waste of money, but also clinically worse for the patient, who then regains that weight rapidly. And the DTC companies that are compounding these drugs are absolutely not surfacing that, because they're just like month to month sell, right? So all of this is at society's detriment. And I think what we need to do is once again support the clinicians and their time and the value of the information we are provided and we can do so much better with that. The plans can, clinical organizations can. So we can have these conversations to say, this is not cost effective or care effective. We need to just come together on that. Thank you.
Thank you. We'll do Adam and then Ken, or David. Sorry.
Really good points. And I think, raises kind of bigger, thematic, higher level conversations that we need to have as clinicians, but then also patient facing and consumer facing in the light of our culture of wanting a silver bullet, wanting the instant gratification of a pill curing everything. And that's not really how the world works. I can tell you about the side effects of the GLPs in my emergency department, patients that I've had to admitted for patients who probably shouldn't, there was no clinical indication for them to be on. So really understanding that just because you want something, maybe you shouldn't necessarily have it from an evidence-based point of view, and having that conversation, understanding the comparative effectiveness, thinking about, resource limitations if you have two drugs where, one may be a little bit less effective, but it's 10x, cheaper, and having that being part of the discussion, which we're all afraid to do from a rationing care point of view, I think is the more really the next challenge we'll need to face. So I do appreciate the comments around how to market it to the public, and of course, how to market it to our legislators and their infinite wisdom as well, about how to utilize this data and change that conversation, or particularly around, bigger concepts with polypharmacy and more is not better, and understanding how we can, be smarter, utilize more real-time data now a lot better than we have historically, just relying on RCTs or other biased research and development as well once it's in application. So figuring out how to be smarter with these new therapeutics, and then of course thinking about back to the point around pharmacy, prescription drug marketing to the general public, around a lot of their R&D was also publicly financed as well. So it's going to take a lot of reimagining, I think, in this effort. And, I do applaud dipping the toes into the water in this. We're going to have a long way to go, but, really appreciate kicking this off.
David?
Yeah, thank you. I want to add my thoughts and congratulations to the team for highlighting these issues. They're very significant. The thing I wanted to mention that isn't intuitive to people outside the industry is that the same drug, when it's injectable or infused, can cost dramatically different amounts depending on where it's infused. So in a hospital setting or an emergency room setting can be 4 or 5, even more times the cost if it's in a physician office setting. I think one of the unintended consequences of this process, when you're applying targets to providers, I think providers are going to try to avoid having exposure to these high-cost drugs. And what I fear is that it's very rational for physician organizations to say, we don't really want the high-cost drugs because it's going to be in our trend and it's going to make it more difficult for us to meet the targets. But for the system, that would be actually stepping back, I know, and it would mean that the costs will be much higher in hospital settings. So just the only thing that's been missing from this discussion for me now has been this issue of where the drug is administered can significantly influence the cost. I want to make sure we bring that into this.
Any final comments from the committee before we go to public comment? All right, seeing that in the room or online, we will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually can click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which your hands are raised. During the public comment period, you will be unmuted when it is your turn. You're also invited to provide written public comment at the email provided on the agenda posted today. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the committee is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the committee may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda except to place the matter on a future meeting agenda. Looking to the podium. Seeing no one, looking online. Beth, I see your hand raised. You should be unmuted on our end. Please go ahead. Beth, we're unable to hear you on our end. You might need to unmute on yours. You should see a mic button with an X in the top right-hand corner of your screen. All right, Beth, we're not able to hear you on this end. I note that your hand has been up for a little while, so we'll try and come back to you or invite you to provide comment at the general public comment period. Looking back to the room and seeing no one in the room. That concludes public comment on this item. We will now move to agenda item number 3, the update on measuring hospital spending.
Thanks, Jane. I'll be covering this item. So I'll be providing some key updates on how OCA will approach measuring hospital spending. And if we just advance to the next slide. So we included this figure to convey how you could measure hospital spending using hospital revenue. So it's essentially prices times volume times intensity would be the equivalent on what we're measuring for the payers and physician organizations, what we're calling total medical expenses. The number and types of services that hospitals provide will affect spending, as well as the prices of the services provided. Next slide. So before we dive in, I wanted to just cover a few terms that we'll use in today's presentation. Case Mix Index, or CMI, is a measure of complexity for inpatient care. It reflects case severity and resource use. For outpatient care, we need a similar measure. Throughout today's presentation, we'll refer to this as the outpatient intensity adjustment, or the new acronym that we're coining is OIA. So both CMI and OIA serve as indicators of the relative complexity and resource demands of the services provided. Next slide. So first I'll cover inpatient hospital spending, and some of this is going to be familiar to you, that to many of you that have been tracking the board meetings or earlier advisory committee presentations. So going on to the next slide. To apply case mix index to inpatient discharges and revenue, we multiply inpatient discharges by the CMI, which yields case mix adjusted discharges or CMADs. The case mix index, as I mentioned earlier, reflects how many resources were needed to deliver care compared to a standardized unit of service. So it's designed to count inpatient discharges in a similar way. Some hospitals focus on less acute community care. Others provide more intensive tertiary services. The CMI essentially is an adjustment factor so that each discharge isn't treated equally. The CMI accounts for the relative resources that were needed. We divide, so to calculate the measure for inpatient spending, we're essentially trying to get to a per unit price measure. The way we do this is we divide inpatient net patient revenue by CMADs to arrive at the unit measure that we're seeking to calculate, which is inpatient NPR per case mix adjusted discharge. So this allows us to isolate price for hospital services by accounting for how much and which services hospitals performed. So you'll see on the step one, it's essentially inpatient discharges multiplied by the CMI. That gives us a new measure called case mix adjusted discharges. And then, as I mentioned earlier, we essentially take the total inpatient NPR and then divide it by the CMADs that we just calculated, and then we get that per unit measure. And then I'll go through an illustrative example on the next slide. So in this example of a hypothetical hospital, these are just made up numbers. So there's 1,400 discharges at the hospital. They have a case mix index of 1.25. When we multiply the discharges by the CMI, we get an updated case mix adjusted discharges or CMADs value of 1,750. We then take the revenue that the hospital generated of $35 million for inpatient net patient revenue, and we divide it by the CMADs figure of 1,750. And then this is going to give us that per unit measure of 20,000 inpatient net patient revenue per CMAD, or on average 20,000 per inpatient hospital stay. So this, all in all, this helps us understand revenue per unit of intensity adjusted care. And then taking us to our next section. So outpatient spending is harder to measure. The care is more varied, more distributed across providers. There's different outpatient services such as ED visits, x-rays. There's visits that are in ambulatory surgical centers. So we simply just count each of those visits as equivalent. They're very different in terms of the resources taken to perform that service. So we need an equivalent factor on the outpatient side, similar to how we have case mix index on the inpatient side. Next slide. So this is the same slide that I showed earlier, just honing in on the focus of today's discussion, which is that outpatient intensity adjustment factor. Next slide. So this is also a stylized example of a hospital with 10,000 outpatient visits. Assuming an outpatient intensity adjustment factor of 1.3. So we're able to take those outpatient visits, multiply it by the adjustment factor, and get a 13,000 adjusted outpatient visits, which reflects the different intensity of the outpatient services at that hospital. And then doing the same thing that we did on the inpatient side to get to that per unit measure. We take the outpatient net patient revenue of, in this case, 6.5 million. We divide it by 13,000 adjusted outpatient visits, and then we get a per unit price of $500 per adjusted outpatient visit. Next slide. So, I gave an example using that 1.3 outpatient intensity adjustment factor. Now I'm going to shift to kind of how would an adjustment factor be calculated. So based on earlier feedback we received from the board and public, we were given suggestions to explore additional options to more accurately account for changes in outpatient service intensity over time. So there's essentially kind of two options that we're exploring. The first one is using APC weights, which are a public open source file available from CMS under their outpatient prospective payment system. And then the second option is a proprietary 3M enhanced ambulatory patient grouping EAPG classification system. Under either option, we would need to use utilization data from the HPD to assess relative resource needs for a hospital. So the first, as I mentioned, APC weights from CMS. These weights are used by CMS to reimburse hospitals for outpatient services based on a predetermined rate. APCs are used to group services and determine payment amounts. In this case, we would leverage APC weights to determine the outpatient intensity adjustment. And then in the second option, EAPGs classify outpatient care into patient groups and categories based on key procedure and primary diagnosis code. The difference between option 1 and 2 is that EAPGs provide more payer-specific weights. So we wouldn't just be relying on exclusively Medicare weights, but we could use commercial-specific weights. And then taking us to the next slide. So this is just kind of further considerations for these two options. Again, both of these can be applied to claims data in the HPD to develop a weight. There are a few differences. APCs will be more transparent as they are a Medicare-based weighting system, as I mentioned, open source. However, there are some limitations for hospitals with fewer Medicare patients, such as those that deliver more maternity services or children's hospitals. EAPGs offer a more refined measurement of resource intensity and are based on all patients, not just those with Medicare. However, this is a proprietary tool and will be less transparent than the Medicare grouper. Next slide. So this is a high-level kind of illustration of how we would apply an outpatient weight to each hospital using HPD claims data, regardless of whether it's APCs or the 3M option. So the first step is, we would apply the grouping software to each hospital's outpatient claims in the HPD. The second step would be sum the relative weights across claims by hospital. The third would be we produce a single outpatient weight for each hospital. And then we would multiply outpatient visits, which are reported in the hospital financial data, by the facility's average relative weight. And then this outcome would produce an adjusted outpatient visit measure. And then taking us to the next slide. So this is similar to what I showed on the inpatient side. We multiply the outpatient visits by the outpatient intensity adjustment factor to calculate those adjusted visits. We would then take the outpatient net patient revenue and then divided by the outpatient visits to calculate that outpatient per unit measure. So taking us to our next slide, validation is essential to ensure that the HPD data accurately reflects our desired population. It's important to know how much data is available and whether it reasonably represents the total population. By comparing other data sources to the hospital financial data, we can assess the completeness and representativeness of the data source. So these are some of the steps in our validation process. So we've performed correlation analysis to help confirm the comparability of HPD for measurement purposes. We want to ensure that the HPD is directionally correct and is representative of our target population. To do this, we have compared HPD data to several publicly available data sources. We have access to inpatient case mix index, that's readily available data, and hospital financial information through the hospital reports. So that's where we've initially focused our attention. In the first step, we've compared the HPD to the hospital financials at an aggregate level, as well as a facility level. We then use these data to perform a correlation analysis to assess the representativeness of the HPD compared to hospital financials. In the next two steps, we'll calculate case mix index from the HPD, and a separate, there's an existing patient discharge data set that includes the case mix index. We'll want to compare how by payer, Medicare, commercial, how those case mix index values generated from the patient discharge data set compare to the HPD, overall and by facility, and perform correlation analyses to confirm the validity of using the HPD. So these are, these are currently in flight, and this will help us ascertain whether the HPD is a valid source for calculating the outpatient intensity adjustment. And then the next slide is just showing, this is what we've already publicly reported about the HPD in a legislative report. So when we compare HPD to other data sources, including hospital financial data, what we do find is that the HPD is a representative sample of hospital utilization. Of particular note, the HPD captures about 80% of California's healthcare experience, specifically 82% of California's total population and 89% of California's insured population. This includes 90% of statewide ED visits, 85% of inpatient admissions, 76 to 89% of office visits. The HPD is not 100%. This is because not all patient populations or payments are included in the HPD. Some examples include self-pay, the uninsured, most of the self-insured, and smaller commercial health plans with less than 40,000 covered lives. Looking across 4 years, in terms of some of the initial validation steps we've taken, it appears that HPD data has the same aggregate revenue and utilization trends as reported in the HCI hospital financial data, which suggests it can be a reliable source of data for the use case of outpatient intensity adjustment. And I'll take us, we only have a few more slides, but just want to cover some additional steps we're taking for validation. We'll continue validating the HPD across payer types and service lines, focusing in on the distribution of patients by sex and age, and assessing per unit charges. These validation steps will give us further confidence that we understand the patient population represented in the HPD, help identify any gaps, and consider variations across care settings. And taking us to our next slide, like other all payer claims databases, the HPD faces gaps in data from the uninsured, as I mentioned, self-insured, non-claims payments, some government payers like TRICARE and out-of-state patients. States have overcome some of these limitations by understanding the magnitude of the gaps and addressing them systematically, for example, by pooling information for facilities with less available data. We're considering these limitations and are factoring them in to our analyses and recommendations. And then on our last slide, we're actively working to finalize a hospital outpatient measurement approach that would account for the intensity of outpatient services. This summer, OCA will reconvene the hospital spending measurement work group to provide input on the intensity adjustment for the outpatient measure. And then OCA will continue to provide updates to the board, the advisory committee, and the public. And with that, I'm happy to answer any questions.
Andrew C.
Yes, so Vishal, thank you again for all the work that the OCA team is actually doing on this front. So I guess on the methodology, I'd probably express a preference for something that's publicly available and transparent. You never know what happens if something's proprietary and things just will change. Whereas with something public, there's usually a process. The other thing is, this hospital thing feels like a trilogy to me, right? You started with inpatient, now we're in outpatient. And I'm assuming there's a third piece, which is how do you put the two together, right? Because you would want to have some kind of composite for the hospital.
Yeah, thank you, Andrew. So regarding your first question about the public source, that's our preference as well. We'll still explore the proprietary one. There may be some limitations too, in case, could we use a proprietary tool to actually publicly report measures? We're still looking into some of the challenges with that. So our preference overall would be to use a public source one. We have heard that, as I flagged, it may not be the most representative for children's hospitals. We have learned that there potentially could be some other CMS weights for children's hospitals that are outside of OPPS that we're looking into. And then regarding your how to combine the measures, that is something that we'll take to the work group. Our goal is to have a combined measure, but then we'll be able to disaggregate it so we could look at what's going on with inpatient. And as many of you know, a lot of the services are going to outpatient. So we'll be able to track those trends over time, and then also be able to report by payer type as well. Will be an important consideration as well.
Yeah, and I really appreciate the validation pieces and also using data that's already being submitted. So I think it shows thoughtfulness that, yeah, we already get a lot of data. Let's see what we can do and not require more data.
David Joyner.
Yeah, thank you for tackling this. It's very complicated. I have a suggestion on outpatient. Well, I know you're trying to adjust using a methodology for outpatient, but the problem I think with outpatient is you have some big categories of services that are just totally different to each other. So an emergency room visit is totally different from a chemo visit, which is totally different from an outpatient surgery, or colonoscopy, endoscopy. So my suggestion would, rather than try to group everything together and have some kind of intensity adjustment factor, I would look at hospitals in terms of the major categories. So you've got inpatient, emergency room, outpatient surgery, infusions. That's probably going to cover most of it. And then look at variation within those categories rather than try to group everything together as outpatient. Because I think you'll end up seeing differences between hospitals which will be more driven by how significant is their emergency room or how significant is their outpatient surgery volume. which will obscure the real differences in affordability that you're trying to identify. So I would encourage looking at that as an alternative approach rather than grouping everything together, which is the way you're.
Yeah, thank you, David. We do need to kind of do the aggregate one just so that similar to how on the payer side we have total medical expense, and on the medical group side being able to have that TME measure of per capita spending or per member spending. So we do need an aggregate one on the hospital side as well. I think, but your suggestion is a good one in terms of like the next level, like the next level down in terms of drilling down. We'll have to see if that's feasible, because it won't tell us why outpatient per unit prices are going up. Like we'll have, that's either a subsequent conversation with the healthcare entity during enforcement, or looking, or further data analysis in the HPD if there's kind of broader trends going on with healthcare.
Joan Allen.
Seconding David's point that a little bit more granularity here I think could be really helpful. Looking on the inpatient side, the case mix index is incredibly helpful, and it's great that we have it consistent over so many years. It does end up getting a little funky as you're trying to compare a psychiatric hospital or a long-term acute care hospital to a general acute care hospital, and you see some almost compression within the general acute care space because those other more specialized and longer term care facilities have such high CMIs. And so a little bit of granularity on the outpatient side could avoid that sort of almost masking of variation among the hospitals that we're most likely to be trying to compare. So definitely appreciate that point of knowing we need to roll up to one number, but how we piece together that number under the hood could give us a lot of information. Also, just thinking about as we're trying to decide between effectively what are two different groupers, one of which generally applies to the Medicare population, one of which is already used by Medi-Cal. We do have all of that data in the HPD currently and could run some validations. We could run, so we've got the APC, which is generally run against the Medicare data. Let's run it against the Medi-Cal data. We have the 3M data that's generally run against the Medi-Cal program. Let's run it against the Medicare data and just see what actually falls out of that. And that actually, I in preparation for this meeting, had been digging a little bit in on like what MACPAC has done. And other states and MACPAC have been down this road some. So I was just wondering, sort of as you're looking back at the literature and at the research that's already been done of trying to direct, what are you seeing of that cross-validation of those that are existing? So we're basically trying to take either a grouper that's in California largely applied to Medi-Cal, or a grouper that's applied to Medicare, and apply it to the commercial market. And just have we dug in on that, or is that work stream in process?
Yeah, we're probably more ahead on the Medicare APC weights and just starting some early conversations with about the 3M one. We don't have access to it right now. We're just exploring the feasibility of it. And then the way the Medi-Cal claims, I don't think the APC weights are in there. Like the claims data we get from DHCS for Medi-Cal patients, like we'll know like the utilization and the payment, but not, it's kind of in the sausage making, like the APC weights are more used to establish the payment, but we won't be able to like unwind the weights. We'll have to apply the grouper once we obtain it. Yeah.
Yeah, I would love for those groupers to be in the HPD eventually. But yeah, if we can get that information and just say, I know that Maryland has been down this path before, other states have been down this path. And so a little bit more of what have other states done and what's been done at MacPac would be helpful.
Yeah, we are, there's not a lot of, we are fortunate to learn from other states like Maryland and what they've done. But the outpatient, getting to a per unit measure of outpatient, it has been tricky in terms of there's not an analog similar to what we have on the inpatient side. So we will be creating something new and helping to kind of close a gap in how states are able to measure outpatient spending.
And then the last question I had is just how we see this playing into some of the non-claims payment. As do we, because the HPD is going to bring us the payment side of things for the first time. And so if I was doing this research, that would be part of what I'd be looking at, would be using cost as a validator or payment as a validator on some of this. Is that possible given how much non-claims payment there is?
So the more important thing for this outpatient intensity adjustment is utilization data. So the claims data and the encounter data, which encounters are reported for entities that are paid under non-claims. So the payment information is less important. We'll still do those validations to just kind of ensure that the trends we're seeing in the on the revenue side and the HCI financials track to what's in the HPD. But it's really more the utilization, which is kind of what service was delivered or received by the patient, that's more informative for the outpatient intensity adjustment.
Tamma?
Thank you. I have a couple of questions. The first goes back to the outpatient intensity adjustment and particularly the 3M EPAG tool. Can you speak to like who uses that right now for reimbursement or risk adjustment? And then also, can you share how DHCS uses it now in Medi-Cal?
Yeah, that's, we've heard that DHCS uses it for hospital reimbursement. Maybe some of you in the room might be able to confirm. We just haven't had a chance to connect with DHCS to confirm that or dig into that. And then it is a tool that payers and sometimes even providers use for kind of internal analytics. And then, but we have heard kind of more of the two, the APCs are used more frequently. Even though they're Medicare weights, commercial plans are using them for their kind of internal analytics they do.
Great, thanks. And with my second question, with regards to the approach for identifying and adjusting outpatient visits, like how do you plan to, or what's your thinking on how to kind of reconcile the different data, right, between the AFDRs and the data from the HPDs in terms of like the definitions for outpatient visits, how you tackle it when different provider information is used, whether it's like the provider IDs versus the licensing license or like the NPI, sorry, and then the timing differences for reporting.
Yeah, so the timing will, depending on how the hospital files, some file based on the calendar year for the HCI hospital financial data, some file based on a fiscal year that's not exactly January to December. So we'll tie that for the outpatient, for the claims and encounter data we're going to use for the to look at outpatient visits. We'll make sure to look at those service dates that tie to the way that the same way that they file their HCI financials, so that it's consistent. And then we're kind of as part of the validation, we're looking at kind of how visits are counted on the HCI hospital financial data and the HPD. The overall kind of gist of it is that the HPD is, we're using it as a sample in terms of, it's not going to cover every single visit or because of, as I mentioned, it doesn't have all the self-insured. But is it giving us a consistent enough signal where those commercial lives are representative of self-insured or kind of no different or no more different? So it's essentially kind of a broad sample or like a way to use the HPD as a sample that's applied to calculate the intensity adjustment.
Any other questions or comments about what Vishal has shared? Oh, excuse me, Stacy Herantis, forgive me, please go ahead.
Good morning. I just think Vishal, thank you very much. Very detailed. The non-claims data, if systems are fully capitated or have significant percentage of capitation, not having that data will be a handicap, and things are very different under capitation than fee for service. So just to highlight the need to get that information, really understand how it all flows through.
Yep. Thank you, Stacy. So I may have used the word claims a lot, but it's claims and encounter data will be used to look at utilization. So the HPD includes encounter data, and then the non-claims payment associated with those encounters, there is a lag in terms of HPD hasn't collected the payment associated with that, but we do have the encounter data.
Thank you for that clarification, Vishal. And just encounter data is only good as the data that gets through all the edits and checkpoints. And I know IHA has done some information on all the encounter data and how it's transmitted to the multiple parties. So just put a note that it may not be complete data.
All right. Thank you.
All right, any other comments or questions from the committee? Okay, Vishal, is there anything more to present, or do we move to public comment now?
Nothing further.
Okay, all right, then we'll move to public comment, and we'll be looking for both individuals in the room that step up to the podium, as well as members of the public who raise a virtual hand. And again, please keep your comments to 2 minutes, and we'll begin with the individual at the podium.
Okay. Does it work? There we go. Yeah, Brad Schmidt. I'm a healthcare CEO here in Sacramento. There's just a quick comment. There's a really excellent transparency website called Sage Transparency if you're looking for claims data. It's from the Employers Forum of Indiana. It was created by Rand. I'm not sure if you're familiar with this public information. You can actually look at margin rates by payer class. You can look at quality measure scores. You can look at unit measures, so pharmacy rates, radiology rates. It's a really good website. I'm not affiliated with it, but take a look. My other issue, so if you take a look at Sage Transparency, the second one I had a question on was the commercial insurance rates. They've increased 300% since 2000. And I'm trying to encourage visibility on these prices. I think there's going to be a significant drop-off in commercial participation. And most of the hospitals I've looked at are negative margin on Medi-Cal and Medicare and Advantage. So I'm just trying to get some information from the room on that subject. And finally, is there any way to build awareness around successful cost-saving measures? So, for example, our nonprofit can save $30,000 per exam versus some network providers. Is there any way to build awareness around that information? So I'm just trying to, that's sort of my comments. Thank you.
Thank you so much. Appreciate it. Don't see any raised hands virtually yet, so we'll move to the next person in the room. Thank you.
Hi, Ben Johnson from the California Hospital Association. OCA's overall methodology has several good features here, most notably insofar as it does seek to avoid penalizing hospitals that see more or more acutely ill patients. There are some deficiencies and open questions that we do hope to address, most notably around whether risk adjustment approaches are fully accounting for, say, some of the sickest patients, the longest stays, and so forth. And while the inpatient methodology is more fully baked and has been vetted by OCA's dedicated hospital spending and measurement work group, the outpatient methodology is not this far along. OCA's preferred approach would wed these two pretty disparate data sources and potentially use the approach for risk adjustment, the EAPG, which there really is not, I think, significant familiarity within the hospital field around, and still lack of clarity when it's used in Medi-Cal and so forth for reimbursement. So we do ask for OCA to work with the work group on these open questions to ensure transparencies regarding any risk adjustment data and methodologies that are used to fully validate the data in line, I think, with some of the plans that have been put forward. We do ask that OCA to bring this methodology as well as alternatives to that work group for feedback and questions before decisions are made. Thank you.
Thank you. If there's anyone else in the room that would like to make a public comment, please step to the podium. There are no raised hands online from members of the public. Okay, that concludes public comment for agenda item 3. We'll be moving on to agenda item 4, update on cost and market impact review program.
Good afternoon, everyone. My name is Brian Kearns. I'm one of the assistant chief counsels for OCA's compliance division, and I'm going to spend some time today just providing an overview of the last year of our cost and market impact review program. Next slide. If you'll recall, our program launched on April 1st of last year. Before that time, we had come to the committee a couple of times to just go over our regulations and how we were establishing the program. And once we had promulgated our regulations in late 2023, the program officially launched on April 1st, 2024. And this slide kind of provides like an overview of the amount of transactions we received, material change notices, and pre-filing meetings. So a transaction can actually involve multiple material change notices. Submitters will file those notices with us when they're ready to close on a transaction 90 days before. And one thing you'll notice in 2024, we had a lot of pre-filing meetings. This was a new program, so there was a lot of questions about how we were implementing this program and the requirements. So we met with a lot of submitters in 2024. You can see that there's been less meetings this year. I think people become more familiar with the program. And as you'll see in a later slide, we have a flow chart along with some FAQs, which I believe have been helpful. So you can see the trends from 2024 to 2025. In 2024, we had 10 transactions with 16 different MCN submissions, 26 pre-filing meetings. In late 2024, we started to see an increase in submissions in material change notices, and that trend has continued through now. We've already had 6 transactions with 10 different material change notice submissions and a couple of pre-filing meetings. I should also point out that we have a CMIR inbox, which you'll see in a later slide. We field a lot of questions from the public regarding our program, and our team is very responsive to those questions. Go ahead, next slide. This should be up to date. We have received another notice that may not be reflected here, but the trends are pretty clear. We're seeing more skilled nursing facility transactions over the past year. We're seeing laboratory acquisitions. We have some physician organization acquisitions, health plans, and one federally qualified health center. And the trend regarding skilled nursing facilities and laboratories has continued into 2025, as you'll see in some later slides. Next slide, please. So our team has been pretty proactive in monitoring the market, trying to determine whether transactions that are close to closing or have closed and did not, and the parties didn't file a notice with us. So we track public information. We work with other state agencies, and we actually get messages from the public via our CMIR inbox, which you can see in the bottom right corner. We get messages from the public regarding transactions that may have required a notice. So when we receive one of those messages, we'll research the transaction and determine whether or not a filing was required. If we believe a filing may have been required, our team will send out a letter informing them of our requirements and requesting a further explanation. We identified and evaluated 3 transactions, and an inquiry letter for at least one of those transactions resulted in a filing with us. And again, we welcome messages from the public regarding transactions that may not have been filed with us. Our email address is cmir@hci.ca.gov. Next slide. This was the flow chart that I referred to earlier. Our team really worked hard on making this clear and easily accessible. So if you're involved in a transaction that may require notice to us, I highly encourage members of the public to review the flow chart, to go through the steps and determine whether or not a filing is required. We've also developed extensive FAQs, which are linked to the right there. Those answer all sorts of questions about our filing process, the cost and market impact review, technical components of our portal. So there's just a lot of information that's very helpful. Next slide, please. All of our notices, as you may know, are available on our website. We've issued waivers for all transactions reviewed to date. When we get a notice, we have the 45-day period in order to determine whether a waiver is required, or 60 days to determine whether a cost and market impact review is required. And during that 45-day period, we'll review 9 factors as listed in our regulations to determine whether to issue a waiver or conduct a cost and market impact review. And those factors generally cover things like cost, quality, equity, market consolidation. We're looking at how can the transaction potentially impact any one of these factors. Labor is also an important consideration for us. And in comparison, so the Massachusetts Health Policy Commission, which we are similarly modeled after, they've had 180 transactions since their inception, which I believe was around 12 years ago, and 6 cost and market impact reviews. The Oregon Health Authority similarly has had 51 transactions with 5 comprehensive reviews. So even though during the past year we haven't conducted any cost and market impact reviews, what you can see in these other agencies is they're relatively rare. Next slide, please. It's going to be difficult to read this slide, and that's okay. It's not a real organizational chart. It's one we've kind of prepared to educate everybody about the types of organizational charts we see. So one thing we request from submitters is they provide us with an organizational chart of their current organization and how the organization may look like post-transaction. And this is an example of charts that we see. So we'll see a variety of entities involved in the transaction or single-purpose entities that were created. We'll locate how the transaction impacts the organizational chart. And one thing that's been particularly helpful in getting these charts is we see similar players that are involved in various transactions like skilled nursing. So we'll get a organizational chart and we'll see, okay, have we seen some of these players before, or is there a trend with particular entities that are acquiring skilled nursing or labs? So these charts have been tremendously instrumental. Go ahead and go to the next slide. This is a similar chart. You can see kind of how ownership will be transferred in a transaction, which can be very complicated and confusing. So the charts do help us better understand the flow of ownership throughout the various entities that are involved. And next slide. So as I said earlier, all of our notices are posted online, and the trends that I outlined regarding acquisitions of skilled nursing and labs and health plans are pretty much reflected here. So I won't go through each transaction, but I'll just kind of give a high-level overview of everything. So we have here the Quest Diagnostics transaction, which is a lab acquisition. We have UCI Health, which is a health plan acquisition by UCI. Next slide. You'll see a skilled nursing facility transaction, another lab acquisition by Laboratory Corporation of America Holdings, acquiring BioReference. Next slide, please. More skilled nursing. That's been, again, a common theme for the past 6 months or so. Lots of skilled nursing transactions. We have two here, which are currently, one of which is under review. The other one was waived on May 27th. Next slide. And another skilled nursing facility. This is a pretty large transaction with many submitters, and it is currently under review. Next slide. And we have one, the ResCare transaction. That's actually an acquisition of intermediate care facilities by National Mentor Holdings. ResCare, which is otherwise known as Bright Spring, is selling off its interest in intermediate care facilities to National Mentor Holdings. California, the other transaction is California Cancer Association for Research and Excellence, otherwise known as CCARE. This is an oncology provider group that acquired California Urology. Next slide, and that one was waived on May 30th. I believe this is the last slide. This is a skilled nursing acquisition by Laser Holdings LLC from West Coast Hospitals, Inc. This generally what we see in some of these acquisitions is a transfer of ownership to one entity and then maybe a transfer of real estate to a separate entity or an entity that's related to the operation, the entity that's receiving the operations. This transaction is still under review, and I think that's the last slide we have with our transactions. Next one. All right, that was a really quick overview. So any questions or comments? All right. Here.
Also noting for the record that we do have committee members attending virtually, and we looked and we don't have any committee members with their hands raised. So we'll move to public comment on this item. Please step to the podium, or if you're attending virtually, please raise your hand. Noting for the record, it looks like we have about 81 virtual attendees, and seeing no hands raised virtually and no one at the podium, I think that concludes public comment on this item, and I believe moves us to the lunch hour. So it is 12:05 at this time. We are set to take a 60-minute lunch, so we will return at 1:05. All right, thank you. All right, good afternoon. Welcome back. So we will resume the Healthcare Affordability Advisory Committee meeting. Now the time is 1:05. Noting for the record, we have about 55 virtual attendees at this point. I'm going to start a roll call for the afternoon. I think we've had some folks join us. So to have a most accurate record for the afternoon, Joan Allen.
Present.
Barry Arbuckle.
Present.
Eliza Arjoyan. Katie Bassler.
Present.
Stephanie Klein. Carmen Comsty.
Present.
Adam Daughtery. Parker Duncan Diaz. I'm going to pause for a moment. If your mic is not on at this point, there is a little switch in the back, but you'll know if you have a red or green light on top. All right, I'll have you just, yep. So Parker is in attendance in the room. Thank you. Hector Flores. Stacy Hiratas,
Present.
David Joyner,
Present.
Travis Lakey,
Present.
Tam Ma,
Present.
Carolyn Nava,
Present.
Mike O'Day, Janice O'Malley,
Present.
Mario Retaza.
Sorry,
All right, I think
present.
Thank you. Sumana Reddy,
Present.
Yolanda Richardson, Christina Rodriguez.
Present.
Thank you. Kieran Savage Sangwan, Andrew C.
Present.
Steve Shortell, Sarah Stroken,
Present, and I was here this morning. I somehow managed to miss the call.
oh, thank you. We'll note that. Thank you. Ken Stewart,
Present.
Suzanne Usage,
Present.
and Renee Williams. And then I note that Adam has joined us, so thank you. All right, that moves us into the fifth item for the agenda. It's the update on behavioral health definition and investment benchmark. I will turn it over to Margareta Brandt.
Good afternoon, members of the advisory committee. In this portion of the agenda, Debbie Lindis and I will provide an update on the behavioral health workstream, including insights from an analysis of historical spending data, an overview of our previous behavioral health investment benchmark proposal, and a new recommendation to focus on data collection and measurement before setting a benchmark that we shared with the Healthcare Affordability Board at their meeting last week, and we look forward to your feedback on this recommendation as well. So on the next slide, as we usually do, just a quick refresher of OCA's statute. So OCA's statutory requirements related to behavioral health include two distinct activities for behavioral health spending. First, OCA is required to measure the percentage of total healthcare expenditures that go towards behavioral health care. And second, OCA is required to set a benchmark for behavioral health spending that sustains infrastructure and capacity and shifts resources from specialty care towards supporting and facilitating innovation and care improvement in behavioral health. And I'll note here also that statute does not require that OCA set a benchmark by a specific date. And now I'll turn it over to Debbie Lindis, Healthcare Delivery System Group Manager, to review the analysis of behavioral health spending data.
Thanks, Margareta, and good afternoon. Go to the next slide. So OCA collaborated with HCI's Healthcare Payments Data Program, or HPD, on an analysis of several years of data in the HPD. We reviewed analyses covered California and CalPERS performed, conducted using their own data. And the data from these analyses provides helpful context for the discussion of the benchmark recommendation that we'll have in just a few minutes. The HPD team analyzed HPD claims over the 6-year period of 2018 through 2023 using a methodology developed by the Milbank Memorial Fund to identify behavioral health spending and provide us with a baseline understanding of mental health and substance use disorder spending via claims prior to OCA starting to measure the spending and set benchmarks. Covered California and CalPERS also used this methodology for their analyses. And as a refresher, the Milbank Memorial Fund convened experts from several states, including California, and our colleagues from Friedman Healthcare to develop this consensus recommendation for measuring claims and non-claims behavioral health spending. You can go to the next slide. Oh, here we go. So a few further things to mention before we review the findings. So first, the findings presented here are preliminary and they're limited to the commercial market. Sorry, you can go back one. Medicaid, Medicare Advantage, and Medicare fee-for-service spending are not included in this analysis. And the commercial analysis includes data from the mandatory data submitters to the HPD, which are fully insured plans and CalPERS, as well as voluntary self-insured submitters. The spending analysis includes claims data that has associated spending in the HPD. And this spending largely reflects fee-for-service payment arrangements, but includes claims-based spending from some other payment types, such as bundled payments. To comply with de-identification guidelines, claims records with fewer than 30 claims were suppressed, and therefore the associated spend was excluded from our analysis. We're grateful to Covered California and CalPERS for also analyzing behavioral health spending from 2021 through 2023 using their claims and encounter databases and following the Milbank specifications. Although both agencies applied the Milbank code set, their methodologies may have differed, for example, in the way they used capitation and encounter data to estimate claims equivalence. So we should consider all of this analysis preliminary, including the HPD analysis, and we should consider the comparisons approximate. Next slide. So this is a proposed process map for identifying behavioral health care in claims data. It's a graphical representation of the process that the HPD, CalPERS, and Covered California teams applied in analyzing their respective data. So starting with the blue box on the top left, the first step is to determine whether the claim includes a behavioral health diagnosis in the primary diagnosis field. If the primary diagnosis field does not contain a behavioral health diagnosis code, the claim may still be considered behavioral health if it includes a service code for mental health or substance use disorder screening or assessment. The orange box recognizes that screening for mental health and substance use disorder conditions is important for prevention and population health, regardless of the resulting diagnosis. OCA believes its measurement approach should incentivize these important services. So if one or more of those services is on the claim, then those lines of the claim are considered behavioral health. So going back to the first blue box, if the claim includes a behavioral health diagnosis code in the primary diagnosis field, then the next step is to categorize the claim by place of service, revenue, and service codes. Any claim that clears that primary diagnosis hurdle will be considered a behavioral health claim. And the second step serves to categorize claims for analysis and later to determine what will be included in comparing spending to the focused benchmark. The separate flow that starts with the blue box on the right side of the slide shows the process for identifying a pharmacy claim to be included in measurement. If the pharmacy claim includes a National Drug Code, or NDC, that OCA defines as behavioral health treatment, then the claim is a behavioral health claim. And all claims will be categorized as either mental health or substance use disorder spending, depending on the primary diagnosis code, or NDC, on the claim. Next slide. So this slide shows how we recommend the behavioral health service subcategories from the process map be rolled into higher level service categories. The categories would be used for reporting and for identifying spending that would be measured against the focused benchmark. So here, the outpatient community-based category that's shaded in blue includes the service subcategories that would be included in the focused benchmark that OCA proposed to our work group, which we'll review in a few minutes. Next slide. So here's a look at the overall trend in behavioral health spending by commercial payers from 2021 through 2023. The Covered California and CalPERS data show consistently that behavioral health services accounted for between 5 and just over 6% of total spending during these 3 years. Covered California data show a gradual increase over time, while CalPERS shows an increase in 2022 and then a decrease in 2023. And both data sources show that mental health services, the blue segments of the bars, account for most of the behavioral health spending, with substance use disorder services taking a smaller share. In the HPD data, the level of spending for behavioral health is higher as a percentage of total claims spending than CalPERS and Covered California found. The HPD data also shows a gradual increase over the 3 years in behavioral health spending as a portion of total claims spend. Go to the next slide. And here we have some data from Massachusetts as a comparison with the California data we just looked at. And this chart shows 2 years of data for commercial payers, Mass Health, which is Medicaid, and Medicare Advantage payers. The commercial segment measurement is comparable to the data we just looked at from the 3 California sources, showing the percentage of total expenses going to behavioral health as 7.7 or 7.8%, with a large majority of that spending being for mental health. Behavioral health spending by Mass Health, represented by the 2 bars in the center of the chart, is much higher than the other 2 categories. And there are several likely reasons for this. First, Mass Health has a higher percentage of members with a mental health diagnosis than payers in the other 2 categories, and a significantly higher percentage of members with a substance use disorder diagnosis. Also, it's likely that Mass Health has a greater proportion of members with dual mental health and substance use diagnoses, and single diagnosis members with more intensive needs. So utilization is probably higher. Mass Health provides more extensive coverage than commercial and Medicare Advantage plans for mental health and substance use disorder services. And Massachusetts has also focused policy efforts through its behavioral health roadmap, which increases access to behavioral health services for Mass Health members. We don't yet have comparable data from Medi-Cal to share, but it's reasonable to anticipate that we will see a higher level of behavioral health spending in Medi-Cal than in the commercial and Medicare Advantage markets in California. Move to the next slide. And here we see the trend in behavioral health spending from 2018 through 2023 from our preliminary analysis of HPD commercial claims data. The light blue portion of the bars here shows the categories of behavioral health spend that OCA is proposing to use for its spending benchmark: in-network, outpatient, and community-based behavioral health services. The gray portion of the bars represents all other behavioral health spending. So a couple of things to point out here. First, there's been a steady increase in total behavioral health spending as a percentage of total claim spending, growing from 6.6% in 2018 to 8.2% in 2023. And second, the increase has been driven by increases in the in-network outpatient portion of the spending, which increased from 2.3% of total claim spending in 2018 to 3.6% in 2023. The rest of the behavioral health spend was relatively flat over this period, meaning that it grew at approximately the same rate as total medical expenses. We can go to the next slide. So the steady increase in the portion of behavioral health spending that OCA has proposed to include in its benchmark, which obviously occurred before the introduction of the benchmark, has implications for our work to set the benchmark. To further inform our thinking, we looked at the annual changes in spending for in-network, outpatient, and community-based behavioral health care. And on this slide, we see the year-over-year changes in the targeted spending measured as a percentage of total claims spending. And we see substantial year-over-year gains in the benchmark measure of in-network, outpatient, and community-based behavioral health spending as a percentage of claims spending, reflecting the trend we saw on the last slide. And these increases reflect the increases in spending in those targeted categories, but those changes are moderated by the growth in total claims spend, which is the denominator of this measure. And the range here is from a 1% increase in 2021 to 18% in 2023. 2021 was a year when total medical expenditures grew significantly, rebounding from the COVID-19 pandemic. And the simple average over the 5 years of increases is about 10% per year. Go to the next slide. So another way to measure behavioral health spending and look at changes over time is as a per member per month amount. And this slide shows year-over-year increases in spending per member per month for the target categories of behavioral health spend. And that increase ranged from a low of 9% in 2020 to a high of 24% the following year, with an average increase of approximately 16% across the entire time period. The year-over-year change in percent of total claims spend that we saw in the last slide is lower than the percent change for PMPM, except for the pandemic year of 2020, and that's because of the moderating effect of the growth of total spend. The PMPM measurement is independent of trends in total claims spending, and it reflects changes in spend that are not the result of changes in membership. Go to the next slide. So we wanted to know more about what's behind these trends, and so we began by looking at the trends in spending for the service subcategories that make up behavioral health care. And this slide shows the percentage of total behavioral health claims by commercial payers attributable to each subcategory by year. And I'll note here that this is the first time HPD cost information is being displayed for behavioral health services, and I'll reiterate that our results are preliminary. So you can see here that the fastest growing components over the period were residential facility services, which grew from 4% of the total to 9%, and outpatient non-primary care professional services, which grew from 33% in 2018 to 43% in 2023. And in contrast, the share of spending for inpatient facility and emergency department services declined over the 6 years, meaning that those subcategories of spending grew more slowly than behavioral health spending overall. We can go to the next slide. And this slide shows graphically the distribution of commercial behavioral health spending across the service subcategories for 2023. And the largest share of the spend at 43% is for outpatient professional non-primary care services. Including outpatient professional primary care, outpatient facility, and mobile services, the data show that outpatient services as a whole account for more than half of commercial payers' behavioral health spending. Go to the next slide. So as we did for primary care, OCA is compiling a list of supplemental analyses that would provide further insight into efforts to increase behavioral health investment, but that would not be part of the measurement of spending using data that payers submit to OCA. The behavioral health spending data we just looked at raises additional questions that could be answered with further analyses of existing and future data. And while these analyses would take time and resources, and they might not be necessary to inform the benchmark approach, they could enhance our understanding of the drivers of spending we just reviewed. So some of the questions we've identified for supplemental analysis so far are these on this slide. Are certain services driving the trend in in-network, outpatient, and community-based behavioral health spending? Are there particular diagnoses driving the trend? How do changes in price and utilization contribute to the trend? And we've seen the average growth across payers, but we wonder, how do trends vary among individual payers? You can go to the next slide. So we presented these analyses to the Investment and Payment Work Group at its May meeting and to the Healthcare Affordability Board at its meeting last week. And everyone appreciated seeing the data on behavioral health spending from the HPD, Covered California, and CalPERS to provide context to the conversations about measurement and benchmarking. While some members were pleasantly surprised by the level of behavioral spending in 2023 and the increases since 2018, others said that it was very consistent with what they expected. And as with any data analysis, the presentation raised additional questions. The work group and board members would like to better understand the factors driving the trends and variation in spending across payers. The board expressed interest in understanding more about the contribution of capitation payments to overall behavioral health spending. And there's also an interest in taking the HPD analysis beyond commercial payers and including Medi-Cal spending. And before we move on to talk about the benchmark, I'll just pause here for any feedback and questions about the data we've shared.
Let's see, David, Sumana, Parker.
Just thank you for this. I think there's a category of behavioral health you're not capturing here. I think it's really hard to capture, so I hate to make an observation without a solution, great solution, but I know that many primary care physicians and many pediatricians will address behavioral health issues with patients. It won't be the primary diagnosis on the claim, partly because these things might be adjacent to somebody just got diagnosed with diabetes or congestive heart failure or something, and there's a behavioral health component to that. But also, if they put the primary diagnosis on the claim, the health plans will reject it and say, no, you've got to bill it to the carve-out company. So the pediatricians and the primary care physicians purposefully will avoid putting it as the primary diagnosis because they don't want to get into that situation. So there, I think you're missing a fair bit of behavioral health that is being delivered to patients here. It's very hard to capture it, but I just want to comment that I think it exists and it's pretty significant. And that's why when you say outpatient primary care is only 2%. I look at that number, I think the real number is much higher than that for both pediatricians and adult primary care.
Yeah, thank you for that flag. We are aware of that as a limitation in our data compared to how people practice. So thank you for pointing it out.
That's a significant part. Thank you, David.
Let me just give it real quick so the folks online know. So we've got Sumana, Parker, Karen, Stacy, Mario, and then Sarah. Sorry, Sumana. Thank you.
Yeah, exactly to that point. Wondering about the accuracy, wondering about how to deal, like the strategic side, the friction created in terms of if the behavioral health diagnosis ever exists in a complex visit I do, does that become primary? How is that going to address the overlap issues you've talked about with primary care investment, behavioral investment, not double counting that and penalizing when good primary care involves a lot of behavioral health. So I too was really struck by how can that be 2% across the board? There's got to be something there, even if it's that small percentage. But then again, as with my earlier comments, to control the rising cost of these other areas does involve having us do more front-end work. And then a last bit, well, I'd love to see, I saw that with Massachusetts, it was MA plan only and not Medicare. Very curious about Medicare, conventional Medicare plus Medi-Cal in terms of this. And then we talked a lot early on about the challenges of capturing out-of-pocket behavioral health spend for patients and families. I was just curious to know how you came up with, that's a whole methodological thing, but how confident you can be about the number you have for that spend. Thank you.
Thank you. Let's see, there were several things in there. So going back to the primary care, we are attempting to capture behavioral health in primary care with a module that I think we mentioned a little bit last time we were here and we'll come back to next time. The limitation of the primary diagnosis is a challenge that we would be massively overcounting if we counted every encounter where there was a behavioral health diagnosis anywhere on it, probably, because it's not always the main focus. So that's just a known challenge. And yeah, we don't have any data to share right now about traditional Medicare, but that's a good flag for sure. And then the challenges of capturing out-of-pocket, like completely out-of-plan spend are very real, and we're working on some methodologies to try to estimate that. And we don't have an estimate yet, but we really are very aware that that's a big issue, especially in this area.
I'll also just add for the behavioral health occurring in a primary care setting, we also anticipate that we could use the HBD to further investigate this and to understand how much behavioral health in primary care is being captured in the second diagnosis or the secondary diagnosis and the third diagnosis, et cetera. So we think we can use the HPD to further understand kind of the distribution of where diagnoses are included on a claim when they're in a primary care setting. And would note that in the primary care setting, all of this behavioral health in primary care spend would count towards the primary care investment benchmark.
I think this is going to be redundant then, but I want to acknowledge and appreciate working with the Medi-Cal, because that's the space I'm in FQHC, and acknowledge how hard that will be, exactly what you've identified with the overlap in that. In FQHC, we get an enhanced Medi-Cal reimbursement, but then we have other limits, so I can't see my own patient and then go send them to see a therapist in the same day. So many clinics, ours is one, they're assigned to me, I close the note, and I might see my patient for 32 seconds. But they've spent 15 minutes with my therapist, but it's entirely under my billing. At the end of the day, it's primary care in our book, and we're doing the right thing for the patient, but how that gets counted can obviously, which bucket that goes in will be challenging.
Thank you. We've got Karen, Stacy, Marielle, Sarah, and then Andrew.
Oh, great. Well, thank you so much for this. I think it's really helpful context to have, even with all the notes on potential missing data and different things. I do want to echo, I think it's going to be really important to get the Medi-Cal data because I think that's going to pick up a lot of the inpatient care that's showing up less on the commercial side because we know, patients get shifted into the Medi-Cal system often when they have that level of need. And so that's one thing. The other thing I just wanted to comment on is a couple of the initial slides you showed the breakdown between mental health and SUD, but that doesn't seem to carry through to look at the categories of spending. Is that because the SUD is so small? Is it not possible to look at the categories of spending broken out by mental health or SUD, or would that be possible?
That is very possible. We have not done that analysis here. This is total mental health and SUD together, but we definitely can break that out in future analyses.
Looking virtually, Stacy.
Thank you. It's interesting during this time period, and it still continues, the access for behavioral health is just atrocious, to find a lack of a better word. So we're trying to look at data to say this is what the demand is, but the demand is a lot greater than what the claims-based information has. And it'll be interesting to see, if more money spent on behavioral health isn't better than keeping the trend on spend at a lower rate. So just a caution, where the data is only as good as it can be, but it really doesn't measure what the true demand is, as well as what people are paying out of pocket just to get care and access on their own. And then the whole COVID aspect of the time period. Thank you.
Thank you. All right, Marielle.
Hi, thank you so much for putting all of this data together. It's great to see it consolidated in some really easy to read graphs and charts. I'm wondering if there's going to be an effort to cross-reference this data with demographic data, in language data, geographic data. We all know that, access and utilization they depend on each other. So wondering if that's going to be the next step as far as processing this data, or when will that be involved?
We can explore that opportunity with the HPD team as part of our follow-up analysis. So we can look into whether that would be feasible.
Yeah, I appreciate that, just because, especially for Asian American, Native Hawaiian, and Pacific Islander communities, the thing about our data is that we're largely number one in the racial ethnic group that seeks behavioral health services less. And so a lot of that has to do with stigma, language access. So really wanting to see how that is, how that data can be disaggregated and cross-referenced with this data. Other things I have questions for, I'm wondering if there's going to be, or if there's inclusion at all, or some kind of supplementary data from schools. I know with the Children and Youth Behavioral Health Initiative, they've really been ramping up some of their work to support behavioral health services, but also because they are launching, or they have launched, an app specifically for youth, and it's going to be in conjunction with peer-to-peer. So I don't think that data is there yet, but just wanted to give a heads up as far as how this is evolving. And I think, something that we're all aware of but haven't yet had a chance to discuss is when AI is involved in that, and the nature of that data and how safe that could be, especially in this time where we're very conscientious of who's looking at our data. And then my other question, as far as primary care, I know we had this discussion prior. I just wanted to confirm that this was still the case, because I know we were deciding which, specialties would be included. Can you clarify which specialties were included in this, in what y'all considered primary care?
Maria, hi, Elizabeth. I'll just start with the question about the Children and Youth Behavioral Health Initiative, and then Margaret and Debbie can chime in. So in terms of whether we're tracking all the components of CYBHI, I don't believe that the spending on Saluna and Bright Life Health would be included if it's not a claims or an encounter captured by the health plans, but definitely school services provided in school settings that are billed to the Medi-Cal plans. And under the Children and Youth Behavioral Health Initiative, there's a requirement both for private, for the commercial plans as well as Medi-Cal. So yes, we'll be measuring school-based services. But I don't know if there's anything you wanted to add, and then the question about the primary care providers.
Well, just kind of thinking about the fact that, everyone, I'm really happy that California is really investing so much effort in all the different ways that people can access behavioral health. But, as we're thinking about virtual services, I'm wondering how this will fit in these types of models. Maybe they don't, but kind of looking ahead as far as, how will we accommodate this type of growth altogether? Because our ecosystem of behavioral health is expanding, which I'm really happy for, but I also want to make sure that we're considering those data points as we're looking at spending and utilization. Maybe that's more a comment than a question, because it sounds like it's not there, which is okay. That's okay. I just wanted to put that in there. Yes. Sorry.
So a few things to note. I'll just add that, so telehealth services are included in this analysis, and they're categorized, captured by procedure codes and categorized by place of service or care setting. And then for the kind of the primary care specialty question, so this analysis is different than our approach to defining primary care. This analysis focuses on using the behavioral health diagnosis as the first, as how we are capturing behavioral health spending, and then we are categorizing it by care setting. So if there's a behavioral health diagnosis as the primary diagnosis and that care occurred in a primary care setting, then that is captured in that primary care service subcategory.
Got it. Okay. Thanks for clarifying that. Yeah, let me clarify my question about virtual services. I'm not necessarily speaking about telehealth. It's just that there's a lot of work that's being poured into like mobile devices and apps and things like that. And then with that, the involvement of peer-to-peer counselors. So just, really wanting to put a pin in that as we think about how we're measuring behavioral health, that we also look into that. So it's separate from what we consider traditionally as telehealth.
Okay.
And then, oh yes, and then let me just make sure I've gone over all my questions. Okay, thank you so much. Appreciate it.
Thank you. Next, we've got Sarah, Andrew, and Joan.
Oh, I think it's working now. Okay, so, and I always have trouble trying to understand behavioral health and primary care. So I'm asking a few questions here, but I do find myself now working in an FQHC in a pediatrics primary care setting as an LMFT. So I kind of am firsthand getting to experience a little bit of that behavioral health and primary care. I notice pediatricians, whether they are NPs, physician assistants, physicians, they have multiple diagnoses, and some of them are like screening for depression or anxiety, and often will have the diagnosis that a child may have, a mental health diagnosis in that note, and this is Solano County is partnership and Carillon, and I believe all of that gets billed to partnership. So I'm wondering, is it true that that gets lost, or is that being accounted for? And one of the reasons why I'm thinking it may get accounted for is because, so right now, all I'm doing is I'm just kind of like a therapist who happens to be in that office. I'm doing individual therapy, so I'm not doing any prevention or early intervention. That is the goal. At this point, they can't find a way to make that financially work, but there is in Medicaid or Medi-Cal dietic services, if you've heard of that. So that's real prevention and early intervention. And I'm wondering, you know, is that how are others doing it? Is anyone enacting it? Now it could be done at FQHCs on the same day as a medical visit. And that started in 2023, but I think it just this year that it started being able to be done at FQHCs or on the same day as a medical visit. So I guess, and even there have been some therapy appointments that I've done where I've used a Z code because I'm not ready to diagnose yet after like one appointment. And state mental health parity law states, or I think it's Medi-Cal, part of the CalAIM project, is that a child doesn't need a mental health diagnosis to get services. And so the carve out, Carillon, rejects my claim and then partnership pays for it. So again, I'm like still trying to figure out, are we really missing things? And does anyone, like, maybe a conversation with whoever is doing the billing would reveal if we're getting paid for these things, if that makes sense. And the dietic services, what I really am excited about with that, if I'm hopefully in the future able to do that, you know, it's about like educating families about ACEs and helping them cope with the stresses of dealing with a medical issue that they're dealing with. And it's not just LMFTs or psychologists, it's PCPs can use it too. And it's, at least for our county, it's partnership, but each county has, and I don't know, not the carve out, but the main Medi-Cal, maybe it's a managed care organization. So again, I guess the question is, are we missing things or are we not in accounting for behavioral health spending in primary care?
I'm going to let Margaret and Debbie answer that. I just want to thank you for your comments, Sarah, and just all of you. I mean, it's why we have this group, and it's so helpful. We couldn't really make healthcare much more complicated than we managed to do in California. It's incredibly helpful to hear. So these issues about care, you know, the mental health or it's not the carve out in this case, it's the mental health contracted plan versus the main Medi-Cal plan, and all the issues you're raising. So just want to appreciate the intricacies of the data that you all are lifting up.
Yes, I think I'll note a few things, and we can also, as we are moving forward with defining behavioral health services in coordination with DHCS for Medi-Cal and how we would capture behavioral health services provided by Medi-Cal managed care plans, we can raise these types of questions with DHCS. And then I'll just note that, you know, in this analysis, the main health plan is, if they have carved out to a behavioral health vendor like Carillon, they are supposed to be submitting all of their claims and encounters to HPD. So we should be capturing that data in this analysis. And then that is also the intention with OCA's future data collection, that if a health plan carves out to a behavioral health vendor, they should be capturing all of that spending and reporting it to OCA as their behavioral health spending. And then also for the Z codes questions, we have looked into that a bit and gotten some feedback related to including Z codes in OCA's behavioral health spending definition. So we can, perhaps we can follow up, Sarah, and ask you which Z codes you're using and make sure we're capturing them in our definition.
And then Margaret, so even regardless of whether Partnership Health Plan was paying for it or Carillon was paying for it, if, like you were saying, if it has a mental health diagnosis, we're going to count it, right?
Yes.
Yeah. So
yes.
even if Partnership pays for it, like Margareta said, they should be submitting Carillon's data, and it's the diagnosis is the key for us in identifying, counting it.
Andrew and then Joan.
Yeah, so I guess, kind of a request for additional analysis. If we could include outcomes or quality type measures, alongside kind of the spending trend, right? Because the trend on a PMPM, if you look at the CAGR, it's 15-20%, right, over this period, and it's still going up. So the only other piece of medical spend that's going up this fast is pharmacy, right? So I think, it's kind of behooves us to take a look and make sure that we're looking at quality, we're looking at outcomes.
Thanks, Andrew. So I think we would welcome feedback on which types of outcomes and quality measures to look at. We have several behavioral health quality measures that we'll be looking at distinctly in OCA's quality and equity measure set, but we also, could potentially look into this in HPD as well. So we welcome, if you have specific suggestions, maybe we can follow up on that as well.
Joan, Sarah, Sumana, Adam? Where's you next? Okay. Oh, you want to answer the question? Yeah, let's do it. Answers.
I mean, anecdotally in the emergency department, we implemented our substance use navigator program, which does intensive counseling, allows us to bill for Suboxone starts in the department through a procedure code. And we've actually measured reductions in ED recidivism. So, looking at some of the tangible, obviously, a lot of different measurements compared to, morbidity, mortality, but medication compliance, reduction in ED return visits, keeping your primary care appointment, some of those easy ones to hit that can actually have demonstrable downstream effects.
Great. Thank you, Joan, for waiting. Go ahead.
Of course. So 2 quick questions. First, have heard over the years LA County talk about the LA County jail system as the largest mental health provider in the country. And so was wondering if we're capturing corrections either at the county or state level.
No, this data does not include corrections data. I think we have heard that flag before as well, and we can follow up to see if there's other ways we could capture that data.
Our THC data includes CDCR data, but the behavioral health measure does not, right?
That might be an on down the road. And then the second is I know, at least I think that in the behavioral health space, it is probably a larger percentage of the care being delivered by entities that are not considered covered providers for OCA. Just thinking about the space, whereas hospitals, easily covered entities, this space is a lot more diverse in that sense. And it would be helpful to get an understanding of how much of this space is the care is actually being provided at providers covered by the statute.
We can look into that and see if we can kind of do a crosswalk of the statutory definition of providers and what we're seeing in the data.
I figured as you're taking things back to the HPD team, but that's just another one to add.
Thank you, Sarah, and then Sumana.
In terms of a steeper rise in spending for behavioral health, if that's what I think Andrew was talking about. Behavioral health, mental health, substance use disorder treatment has been historically neglected and not provided at the same rates as all other care. So I think especially with our state passing 2 really important mental health and substance use disorder treatment parity bills, I believe in 2020 and 2022, that increases insurance companies' health plans' responsibility to cover not just, I think it was 5 diagnoses before, and now it's all of the DSM, that may have something to do with it. And also SB 221 in 2022, I think that put some regulations on return visit wait times for mental health therapy appointments. So I think a steeper rise in spending may reflect the historical under provision of the services and the recent laws mandating an increase in provision of these services. I had one more thing. I almost forgot. Locus and CalLocus. So those are level of care tools that I believe DMHC requires plans to use. And that would be a way of measuring quality in terms of you can determine is somebody receiving the care that is clinically indicated. Now it's a tool, so clinical judgment comes into play, but it is something I believe that already DMHC does require.
Simona.
When Andrew brought up the thought about outcomes, and then immediately I thought about that complexity, what Adam offered around emergency use. But for us in primary care, it's so much nuance. I'm still thinking technically and choking on this primary, secondary. It's hard not to get into the weeds, but I want to point out that a lot of the screening measures that a lot of this APM stuff is requiring, it's onerous. We're doing a lot of it, and then it should not be discounted because it is surfacing in those visits, in every single visit where I am treating, surveilling, maintaining treatment, including medication for behavioral health. It is having a significant impact on every other diagnosis. So if you're going to do this in a robust way, you're actually looking at, how we got into the opioid crisis with measuring pain scores. Well, if you're really looking at every visit where chronic pain is twinned with depression or anxiety, a good primary care clinician is deeply impacting both. So yes, ED, not just for substance use, is powerful because if I can keep people out of the hospital or every other higher level of care by taking care of that nexus of behavioral health and physical health, I think it can be measured. It's just going to take actually strong clinicians to figure out which diagnoses pair with behavioral health and have that impact. So.
Thank you. Marielle, I see your hand is up. I'm not sure if that's from your previous comment. Do you want to add?
Oh, I'd like to add if that's okay.
Yep.
Thank you. And I just wanted to say that I agree with everyone's comments. It seems really difficult sometimes to capture behavioral health in, medical billing. So I think, I just wanted to, again, highlight the importance of finding a way to include information on behavioral health and utilization that may not be fully codable. And again, I'm going to use the Asian American, Native Hawaiian, Pacific Islander community as an example where, if you have, let's say, a young person and they're visiting their primary care physician or any kind of primary care services, here, and they are, for whatever reason, don't want their parents to know. And I think that's a very common problem because of some cultural and stigma aspects, but also, just kind of thinking about, well, in these situations where you already have a demographic or a group that already may be hesitant, right? I want to make sure that safety is still prioritized, and I'm not really sure that this model could do that for this specific type of people. So, just wanted to give space to and put a pin and, really ask us how do we further unravel that data of all of that data that goes into behavioral health, all that spending, all the services before they get a specific diagnosis. And that's not just in these, clinic and hospital settings, right? This is also in other settings. So that's a big task. I don't know how to do that, and I'm happy to work with folks here. But I just wanted to remind everyone, like, so much about behavioral health, and others have expressed it before me, come before this data that we're seeing here.
Thank you. Yes, it's a great flag. I think just a reminder of kind of the scope of our data collection is through health plans. So that is, a limitation of OCA's data collection. But we are looking at ways to capture behavioral health spending occurring outside of that scope. And we will also note that within our scope, we are capturing non-claims behavioral health spending. So not just claims-based behavioral health spending, but also looking at spending that is not associated with claims. But yes, this is an ongoing challenge for us to think about how to capture behavioral health spending more broadly, including things that preventive type care and services that are occurring upstream. Okay. I think if that's all the questions on our data analysis, and we'll turn to our next portion of the presentation where we'll share with you all our behavioral health benchmark proposal that we previously shared with our investment and payment work group in May and review their feedback, as well as the board's feedback on our revised recommendation. So thank you all for the really great discussion on the data and suggestions for additional analysis. So turning first to a reminder of our proposed benchmarks, we can go to the next slide. So this slide is a reminder that OCA's benchmark proposal thus far has been focused on in-network, outpatient, and community-based behavioral health services. And for claim spending, this means the 4 subcategories listed on the top of the box, the top box on this slide, as defined by diagnosis, service, place of service, and revenue codes. And the lower box includes non-claims payments that would be part of the benchmark, including payments to providers for population health and practice infrastructure payments, pay for performance or pay for reporting payments, and the portion of capitation payments that are for services in the outpatient and community-based care subcategories. And these would be, this portion of capitation payments would be identified using encounter data. So on the next slide, just again, a quick reminder of the other benchmarks that OCA has adopted, which have some bearing for how we're thinking about the behavioral health benchmark. Of course, we have the healthcare spending growth target phased in from 2025 through 2029. We have the alternative payment model adoption benchmark and the primary care investment benchmark, which both combine short-term incremental improvements and long-term goals. And those short-term goals are really intended to acknowledge that payers are at different starting places and that improvement is expected for all. And then, of course, all of these benchmarks reflect long-term policy goals. And if we could go to the next slide. So this slide summarizes a proposal that OCA brought for the behavioral health investment benchmark to the investment and payment work group in May. So this is a draft proposal that we brought to the work group in May. We proposed that the benchmark would be implemented in 2 phases, largely because of uncertainty about where payers are starting in terms of their outpatient and community-based behavioral health spending, and the related uncertainty of how to set an achievable and appropriate target for improvement. The first phase would cover performance years 2026 through 2029 and would require each payer to increase its spending on in-network, outpatient, and community-based behavioral health care by a set percentage each year. The percentage would be informed by trends in the spending before the benchmark was implemented, and 2025 would be the baseline year, with increases expected over the following 4 years.
And the baseline spending amount would be derived from each individual payer's spending in 2025. So OCA would assess each payer's performance against the benchmark every year, and then in 2029, OCA would use 2027 data to assess each payer's performance to date and make decisions about the next phase of the benchmark. So moving to phase 2, in 2029, OCA would update the benchmark for performance years 2030 through 2034, informed by the experience of the first 4 years, and would reset the annual incremental benchmarks and would also consider setting a long-term benchmark across all payers to be achieved by 2034. And this 2034 timeline aligned with the long-term goals of, or the long-term timelines of the primary care investment benchmark and the alternative payment model adoption goals. And then, of course, at this point, or if not sooner in this phase 2, OCA would also incorporate benchmark for Medi-Cal payers in collaboration with the HCS. So moving to the next slide, the presentation of this benchmark proposal fueled a lot of really thoughtful discussion at the work group. Overall, there was support for an iterative phased approach. However, there were a number of reservations about the proposed benchmark, which in many ways were consistent with our rationale for applying a phased approach. So based on the preliminary data analysis that we presented to the work group, several work group members were interested in knowing about past trends and drivers of the growth in behavioral health spending, including the variability in spending increases from year to year. There was also a desire for clarity that the benchmark would support equity and access goals. One concern was that the benchmark would not capture programs that promote equity and access outside of claims-based care. The uncertainty about payer-specific starting points and lack of information about what is the right level of spending to be targeting made some members apprehensive about setting specific targets for annual growth in spending. And members raised questions about how payments for specialty mental health services under Medi-Cal would be incorporated into the benchmark. And there was also a suggestion to further refine the benchmark to focus on integrated behavioral health and primary care. Moving to the next slide. So based on all of the work groups' input and further discussion internally, OCA prepared an updated recommendation, which we brought to the board at its June 9th meeting just last week. OCA proposed to defer setting the benchmark until spring 2028 and apply it to spending in performance year 2029 and onward. And the benchmark would be set based on data that OCA would collect from payers for performance years 2024 through 2026, on further analysis of HPD data and an assessment of the impact of behavioral health policy efforts that are now being implemented in California. So this approach would allow OCA more time to learn from the data that the payers submit for measuring behavioral health spending before setting a benchmark. It also would allow OCA to identify and resolve any challenges in the data submission process. The definitions of behavioral health spending and the data submission process and measurement protocols are, of course, new or will be new, and we could benefit from some time to better understand how payers submit the data and make any necessary adjustments. It would also provide OCA time to conduct further analysis in HPD, like we've talked about today, doing a lot more deeper dives into the HPD data to understand trends that we saw in the preliminary analysis. And of course, the trade-off of this approach is that compared to adopting a benchmark this year, this delays the benchmark implementation and delays the impact that our policy goals would have. So moving to the next slide. So this next slide summarizes the feedback we received from the board. So generally, the board was receptive to delaying the adoption of the behavioral health investment benchmark so that more data could inform our benchmark recommendation. However, some board members thought waiting until 2028 was too long and suggested that OCA revisit setting the benchmark in 2026 based on further analysis of HPD data. we would not have OCA submitted data by 2026. They suggested that in the meantime, we should continue with our analysis of HPD data and then assess next year whether information is sufficient for setting the benchmark. And then if not, the board could consider the benchmark again in 2027. The board also offered additional feedback. Board members thought it was important, again, to incorporate county-based specialty mental health services into the measurement and benchmark process as soon as possible. The board was interested in a summary of the programs and funding supporting behavioral health transformation in California, as these programs will likely influence spending. They were also interested in learning from the experiences of other states that measure behavioral health spending and have spending benchmarks. Massachusetts, as we saw earlier, measures behavioral health spending, and then Rhode Island is the only other state with a behavioral health investment benchmark. And then in regard to the methodology for measuring non-claim spending, board members warned about potential for overestimating the amount of capitation payments attributable to behavioral health. So on the next slide, we have our proposed next steps. So taking all of this feedback into account, these are our proposed next steps. So at the investment and payment work group coming this Wednesday, we will present an update on the benchmark recommendation and discuss feedback that members have offered to OCA so far on the behavioral health definition. And then in July, the work group would finalize the definition and the associated code set, including specifications for the behavioral health and primary care module that we discussed a bit today. And then at the July meeting, or potentially in August, the July or August board meeting, OCA would present definitions and a code set for the board's review and distribute them for public comment. And then the work group would wrap up its work on the behavioral health definition and measurement methodology in its August meeting. And then we would come back to you all in September with a presentation of the definition and code set, and of course, and review public comment that we've received on the definition. So this is our proposal based on to focus on spending measurement, and also alongside this, we would continue to work on our HPD analysis and with the HPD team. So on the next slide, we'll just pause here again for your questions. Any further reactions you all have to the spending data that we looked at, and your thoughts about our recommendation to take a little bit of a step back and focus on measurement first, and to defer setting the benchmark until at least 2026 based on further HPD analysis.
Okay, we'll take a comment from David Joyner.
Yeah, thanks for this. Look, I understand the dilemma, which is it's difficult to measure behavioral health spending, and you've ended up having to spend the things that are most easily identified. But I worry that this direction in general is going to continue the problem we have in behavioral health, which is the lack of integration with primary care. So if you were to ask one of our primary care physicians their experience of referring to a specialist, say orthopedics or pulmonology or cardiology, they would tell you that they are used to getting feedback on a treatment plan from the specialist. They know what's going on. They know if drugs have been prescribed. If they refer a patient to behavioral health, it's going to a carve-out vendor where there's no sharing of information at all. And so usually the physician doesn't even know whether there's been a consultation. They don't have any notes. They don't know what's been prescribed, etc. And so I'm a bit worried that this, from a policy perspective, this is really going to reinforce, if you set a target to spend, but the definition of spending is stuff that you can measure as being specific for behavioral health and not integrated with primary care, you're just going to reinforce that problem, in my opinion. So I think I'm glad you're rethinking it. I think you've got to rethink the whole area of behavioral health and primary care integration. The second thing I'll say is I don't understand. I have the same issue with the primary care. If OCA is going to say total healthcare trend should not go above 3.5% for the first 2 years, Meanwhile, we're going to ask the healthcare system to increase spending above the natural level for primary care and behavioral health, which I think is the right thing to do. If there's no adjustment to the overall target, then what that inevitably means mathematically is now you're shrinking investment in other areas. I don't know whether that's feasible. So I think if we're going to propose these kinds of specific targets, we need to have a better answer from a policy standpoint of how do we deal with the dilemma if you increase in one space and you don't have an ability to decrease in other places, and how does that work? How do you pick, if you're a healthcare organization, you either pick meeting the target overall, or you meet your behavioral health or primary care target? I think we've got to think through how that would work.
Thanks very much, David. Just on the last point, the reason that we actually have these primary care benchmarks is specifically because the research has shown that it is a cost-reducing strategy. So I think the strategy was pretty thoughtful and comprehensive in its approach. And so I think we talked about this with the primary care threshold, that the view is that if you invest more in prevention or early intervention, it will reduce overall costs. So we understand that there may be a ramp-up period.
I think that's right, but remember, you've set a goal that's below medical cost inflation. So I don't doubt that it has a favorable impact, but you've already set a goal that's way below when you look at pharmacy costs and underlying medical healthcare costs, medical expenditures. I think you've ended up setting a target that's below the cost inflation. So I don't know that it's going to be enough to get there.
Thank you, David, for the feedback on the behavioral health and primary care integration. We do really want both the behavioral health benchmark, even if it is, we do not implement a benchmark this year, want both the behavioral health benchmark and the primary care benchmark to incentivize behavioral health and primary care integration. So based on our previous proposal, that behavioral health occurring in a primary care setting would count both towards the primary care investment benchmark and the behavioral health investment benchmark. But we're happy to continue to iterate on that and think about how to better capture that spending or incentivize that spending moving forward with further analysis.
And I do recognize it's incredibly complicated and difficult to do this because of the way it's embedded within regular primary care visits. So I recognize it's very difficult. Yeah.
Sarah Sorokin?
I would advocate for creating a benchmark as soon as possible while collecting more information. And maybe that is, I think, like an alternate recommendation was like 2026, I think that was, like a sooner time, only because, well, one, we all know mental health and substance use disorder treatment is, people are not getting what they need. And so we need to see that spending rise, or the proportion of spending dedicated to that. It'll have real impacts to people. I mean, again, everyone probably knows this, how suicide rates, overdose rates, all of those keep going up. I mean, these are people who most likely struggle to get consistent care or care at all. So it has a real, there's a real urgency to doing everything we can to encourage insurance companies and health plans to invest more in behavioral health. And again, it's a very preventative thing, even though it's maybe this kind of treatment isn't technically prevention work. It is prevention work in terms of physical illness, or at least that's what the research shows about mental health playing a large role in in comorbidities and the severity of illnesses. And also, well, I'll leave it at that right now, but that's my, that's what I implore.
Thank you, Sarah. Yes, the board, several board members recommended we revisit setting a benchmark in 2026 based on further HPD analysis.
Mariel Reyataza.
Did I do
Are
it?
you able to
Okay.
unmute? There
Yes.
you go.
Yes. Thank you. Don't ask me to be IT, please. So, no, I echo the sentiments that have been just shared. I think integration is so key, and it's so difficult given the fact that we're already entrenched in this system. So I appreciate the decision to really consider, what benchmarks we will be using and so forth. Something that I also, am curious about, especially in these times where we may be heading into some more conflict with the federal government. I'm wondering, if in addition to cross-referencing this data with demographic and geographic data, I'm wondering if there's a way to even understand where if any of these added services that are being utilized, programs, et cetera, are coming from folks who are recently migrated to moved to California, even from within the U.S. So just curious about that. I don't know exactly how within California you're going to use that, but I assume that, with the loss of services across the nation, I think it's safe to assume that there's going to be some move into some states such as ours.
Thank you. We can look into whether we might be able to explore that. I'm not sure off the top of my head, but we can definitely look into that.
All right, Karen Savage-Sangwin.
Thank you. And I think I would generally agree that, I understand the questions that need to be addressed, and so it makes sense to delay, but 2028 does seem very far away. So I would generally agree with the feedback you got from the board here. And in that time, would encourage you to at least do a little bit of analysis on the mental health versus SUD, and should that all be one benchmark? That's not sort of clear to me, particularly given the very low spending on SUD and how much unmet need there is there, as well as how much non-evidence-based treatment people are getting over there. So I think that might be an important thing to look at. And the question I have is on the county specialty mental health services, can you just talk about what's needed to be able to incorporate that, or sort of what the next steps are, at least for the Medi-Cal part of that?
Sure. So for county behavioral health, we are collaborating with DHCS on a regular basis to look at that. We do have access to kind of high-level data on the county behavioral health spending through HPD, and we're exploring how we can get that within our OCA data analysis and how granular it can be. We're learning as we go about how those claims through the short dole system are handled and what we can actually get.
Oh, so are you saying the issue is that you have some high level information, but you don't have it in the same categories you're looking at here? Is that
right now we don't, and we're really still exploring what's available through the whole billing system, which is completely different from regular other billing types. So we will definitely come back. We are absolutely looking into that, and we'll report back as soon as we have more information about how we can do that.
Sarah Sorokin.
This is just a comment on maybe the difficulties with collecting information on specialty mental health services. I know sometimes Medi-Cal, their rollout of regulations can be a little bit behind. I might be wrong there, but timely access requirements, for example. At least to my best knowledge, and I just was working at behavioral health, and now I'm over at family health, but when they measure access to first treatment appointment, they're just doing kind of a broad brush or broad stroke whatever that saying is, and measuring from the assessment, which I would do, to the first medication evaluation, and people would be on wait lists for months for all other kinds of services. So the data that you get may, be very incomplete and not reflective of the actual demand.
All right, any other questions or comments from the advisory committee? And then we'll take public comment in just a moment, but any other committee members? Yeah, Andrew C.
Yeah, just probably echoing David's comments earlier about making sure to take a look at primary and mental health integration. The other thing is within the context of the spend target, right? So if you have a piece that's 8% going double digits, it's a big chunk of that. So I think we have to think through kind of the reasonableness of phasing that in over time. And the other thing is, I guess to the extent that a lot of the spending is mandated by state requirements, as Sarah kind of mentioned earlier, I don't know that we can measure that. That's probably worth thinking through how much of it is really kind of new requirements that are being mandated by the state. And again, it's just to contextualize spending, right? Because, the target is very, very aggressive.
Sarah Sorokin.
And this, again, is another kind of related point where just an anecdotal example. So with Cal-Aim, Sac County, and Solano County have had to bring in moderate to severe patients, Medi-Cal, Kaiser patients, into the county behavioral health system recently. And before I left for family health, I was seeing records from Kaiser. And I knew this from working at Kaiser before Solano County, but a lot of psychiatrists and therapists will put a longer wait won't be a detriment on the health of the patient in terms of waiting longer than the 10 business days for a follow-up appointment. And I would see that all the time in records. And again, just to, I guess, make note of the data, you have to kind of really look more in a detailed way to make sense out of it, because it may not be what it seems.
Thank you, Sarah. Thank you, Andrew.
Margaretta, Debbie, anything else before we turn to public comment? No, that's it. Okay. All right, well, then we will be taking public comment at this time, both from individuals in the room who may come to the podium. We'll all be also be looking for raised hands from attendees who are virtual. Please keep your comments to 2 minutes or less. And again, just to reiterate, staff and committee members are not in a position to answer questions, but we appreciate this public testimony. And with that, we'll look to the person at the podium. Thank you.
Yeah, Brad Schmidt again. Yeah, actually, I had a radiology center in Inglewood for about 15 years. I created it to build bridges to healthcare access. I found one of the biggest barriers to what you're discussing in mental health and particularly Medi-Cal health is the Medi-Cal target payer rate in the market is about 78% of Medicare. So the pay rate's super low. And this is sort of a policy comment. The Knox-Keene law, which was created in 1972, has a medical adequacy for care at 15 miles from the patient's home address. I'm wondering if it could be possible to measure the distance from the care location to the provider's address. If there is one, I think that's a big determinant of health. The other one we saw a lot of in LA was interoperability. It's kind of alluded by David, I think. There really isn't any interoperability on the FQHC side, so it'd be helpful to kind of discuss and understand those. From the superutilizer side, it's about $60,000 per person. So I was friends with the CEO of a local hospital in LA, and he had one person readmit 175 times in a calendar year. So I'm not sure if there's some of the super utilizer data you could also incorporate into like a readmissions kind of idea around mental health, because I think they're all related. And the data I've seen on the super utilizers is as high as $275,000 per Medicaid member per year. So it's significant statistics. Anyway, just some comments from my experience in Los Angeles. Thank you.
Thank you. Don't see any raised hands from members attending virtually, so back to the podium.
Good afternoon. Jenny Nguyen from the California Hospital Association. On the timeline of setting the benchmark, we think giving more time for OCA to gather data, conduct additional analyses, and assess recent behavioral health reforms reflects a thoughtful approach. We want to flag, though, that this could affect the spending target measurement as it relates to promoting investment in behavioral health, and that this will need to be recognized. We also want to lift up again our request that OCA includes claims for residential and inpatient care in setting the benchmark. We have strong concerns that only including outpatient care in the benchmark ignores evidence-based treatment models and the need to ensure growth in access to care across the entire continuum. Thank you.
Thank you. There are no raised hands online, and we see no one else approaching the podium. So with that, we conclude public comment for agenda item 5, and we'll move to agenda item 6, baseline report briefing.
Good afternoon. My name is CJ Howard. I'm the Assistant Deputy Director over the Healthcare Spending Targets Branch. We're going to go over some key highlights from the baseline report, which was published a little over a week ago. Go to the next slide. So I want to start by acknowledging what a monumental team effort this was. I truly wish that we could have one staff member present each slide, but for efficiency's sake, it'll just be the three of us today. I also want to thank the commercial and the Medicare Advantage plans for their collaboration in this inaugural effort to gather and report total healthcare expenditures for the state of California. And I'm going to provide some background on the data collection engagement. So starting in September of 2022, OCA facilitated multiple technical work groups with data submitters to address reporting questions, clarify specifications, and provide technical assistance throughout the submission process. Through the summer of 2024, OCA accepted and reviewed test submissions in advance of the formal submission window to ensure system readiness and to troubleshoot data formatting issues. In the summer and fall of 2024, OCA performed data validation and engaged directly with submitters to resolve discrepancies, clarify anomalies, and support resubmissions as needed. In November and December of 2024, OCA held individual payer preview meetings with all data submission guide submitters. That is those entities who submitted commercial or Medicare Advantage data to review preliminary results, ensure accuracy, provide transparency regarding how the data would be reflected in the final report. For Medi-Cal spending, OCA has actively collaborated with the Department of Healthcare Services to collect, review, and validate Managed Care Organization, or MCO, data submitted through the state's Medical Loss Ratio, or MLR template. OCA collected commercial market TME, that's total medical expense, directly from payers, but not comprehensive admin costs and profits data. For the commercial fully insured market, OCA collected administrative costs and profits amounts from CMS's Center for Consumer Information and Insurance Oversight, or CISIO, medical loss ratio data. A few submitters also voluntarily reported administrative costs and profit data for self-insured commercial plans. In the baseline report, we note that commercial administrative costs and profit spending is understated due to incomplete reporting. For the Medicare Advantage market, OCA used two data sources to calculate administrative costs and profits. For large insurers, OCA used the medical loss ratio data collected by CISIO, and for small Medicare Advantage payers who are not required to submit data to CISIO, OCA used data from the plan's annual financial filings with the Department of Managed Healthcare. Go to the next slide. This graphic provides a reminder of how OCA defines total healthcare expenditures, or THCE, as being composed of the total medical expense, which includes claims payments, non-claims payments, and member cost sharing, plus health plan administrative costs and profits. These components form the foundation of OCA's baseline report and spending target monitoring. Go to the next slide. The report presents results at both the statewide and market levels, as shown here. Each major market, Medi-Cal being orange, Medicare being purple, commercial green, and others gray. The color coding is further broken out by coverage type to reflect how data are analyzed and reported. I'm now going to hand it over to Vishal for a high-level overview of the substance of the report and the initial findings.
So this slide is an overview of the changes in total healthcare expenditures and changes in total medical expense. It captures a few of the more aggregate figures presented in the report and gives us a glimpse of an estimate of total statewide spending in California from 2022 and 2023. In our next report, we'll feature spending and growth from 2023 to 2024. So for changes in THCE between 2022 and 2023, total healthcare expenditures, which includes administrative costs and profits for health plans, changed as follows for the three major markets. Commercial spending grew 5.8%. Medicare non-duals, Medicare spending including duals grew 6%, and Medi-Cal spending grew 6.5%. When we look at it at a per member per year growth rate, Medi-Cal and Medicare averaged about 2.9% and 5.4% respectively, while commercial grew at a rate of 6.4%. When we take the major market spending and combine it with other state and federal healthcare program spending, the aggregate total healthcare expenditures on a statewide basis totaled $377.6 billion in 2022 and $408.6 billion in 2023. Which is an increase of $31 billion or 8.2%. And then on a per capita basis, this would be taking those totals that I just stated and dividing it by California's population. Total healthcare expenditures per capita were $9,676 in 2022 and $10,847 in 2023, which is an increase of about $811 or 8.4%. And then shifting gears to TME, growth in spending varied across markets, payers, regions, and service categories between 2022 and 2023. When we look at total medical expenses per member per year, the growth rates among Medi-Cal and Medicare, including duals, averaged 1.2% and 6.1% respectively, compared with an average of 5% for commercial. And taking us to the next slide. So this slide provides context for OCA's work and shows how various key consumer affordability measures have been outpacing growth in household incomes. Over the past 20 years, the financial burden on California workers with private coverage, driven by rising deductibles and their share of premiums, has grown faster than total premiums and median household income, highlighting a persistent affordability challenge. And moving on to the next slide. So these are visuals of the numbers I mentioned earlier. So the first two bars on the left are the total aggregate statewide total healthcare expenditure dollars in billions. And then the figures or the bars on the right are the per capita values. And then going on to the next slide. So here we have a breakout of spending by various market segments. Commercial spending was $120.8 billion in 2022 and $127.8 billion in 2023. So this is a roughly $7 billion or 5.8% increase. Commercial spending overall is about 31% of 2023 statewide THCE. When we go to Medicare, so this is a figure that excludes duals. Spending was 106.3 billion in 2022 and rose to 112.6 billion in 2023. This was an increase of about 6.4 billion or 6%. In 2023, the share for Medicare, excluding duals, was 28% of statewide THCE. Shifting to Medi-Cal, so Medi-Cal spending overall was 125.9 billion in 2022 and 134.1 billion in 2023. This was an increase of 8.2 billion or 6.5%, and the share was 33% of statewide THCE. And then for duals, we include a separate breakout here. So this includes dual eligibles in Medicare Advantage plans and D-SNPs. So these are dual eligibles and special needs plans. So they represented about statewide, on a statewide basis, about 2% of statewide THCE, but the spending grew 35% from 6.5 billion in 2022 to 8.8 billion in 2023, which in dollar values was an increase of 2.3 billion. So just want to provide a few remarks on Medi-Cal spending. There still is some spending listed as other DHCS spending, which includes some other DH spending, which includes Medi-Cal spending and non-Medi-Cal spending. So we got most of the Medi-Cal spending in the listed, the numbers I mentioned earlier, about 125.9 billion and 134.1 billion. That's the lion's share. There's still a few buckets of spending that we're still trying to work closely with DHCS in terms of understanding if it's purely Medi-Cal or non-Medi-Cal. So some of the ones that have been bucketed under other spending include Medi-Cal spending for dental and IHSS, and some non-Medi-Cal spending for some of the niche programs related to genetically handicapped persons program, breast and cervical cancer treatment. We plan to work with DHCS for future reporting years to reclassify some of these dollars. It's some of the complications for why they're not bucketed with the broader Medi-Cal program spending is some issues related to calendar year versus fiscal year reporting. Some of the way that the DHCS numbers that we derived are some are on a cash basis versus accrual-based accounting, and then there's time lags associated with how long it takes for payments to get out. And then with that, I'll turn it over to Andrew to cover some of the more details related to market level, payer level, service category, and geographic reporting.
Thanks, Vishal. So on this slide, we're going to show total healthcare expenditures on a per member per year basis, or PMPY, by market category. And so we can go from left to right here, starting with the commercial market. We see that THC per member per year was just under $7,000 in 2022 and just over $7,400 in 2023, which represents a relative increase of 6.4% and an absolute increase of $443. As for Medicare, including duals and D-SNPs, THC per member per year was $17,879 in 2022 and $18,851 in 2023, an absolute increase of $972 and a relative increase of 5.4%. And then finally, rounding out Medi-Cal, THC per member per year was $8,343 in 2022, and then just under $8,600 in 2023, an absolute increase of $243 and a relative increase of 2.9%. We can go on to the next slide, where we're going to focus on TME per member per year, both in dollars and then the respective growth rates across those three major markets. And so TME per member per year for the commercial market was just over $6,500 in 2022 and a little over $6,800 in 2023, an increase of $326 or 5.0%. As for Medicare, including duals and D-SNPs, that figure was a little over $17,400 in 2022 and just over $18,500 in 2023, an increase of $1,064 or 6.1%. And then finally, Medi-Cal, where we're pooling both managed care and fee-for-service, TME per member per year was a little over $7,900 in 2022 and a little over $8,000 in 2023, an increase of $95 or 1.2%. Go on to the next slide. And so last Monday when we presented to the board, there was considerable interest in a figure that was featured in the baseline report, but not in those slides. It's centered on administrative costs and profits by market. And so in this particular slide, we brought that to the fore here. And so you can see market level THC per member per year, where we decompose that TME and those administrative costs and profits. So starting with the commercial market, administrative costs and profits per member per year spending was $463 in 2022 and $580 in 2023, an increase of $117 or 25.3%. And then in terms of how to contextualize those components, so commercial administrative costs and profits per member per year accounted for about 8% of commercial THC in 2023, up from 7% in 2022. Moving on to Medi-Cal managed care, here administrative costs and profits per member per year was just under $500 in 2022 and increased to $625 in 2023, an increase of $129 or 26%. And for Medi-Cal managed care administrative costs and profits, those accounted for about 15% of THC in 2023, up from 13% in 2022. And then finally, Medicare Advantage administrative costs and profit spending was $964 in 2022, decreasing to $741 in 2023, which represents a $223 decrease or a decrease of 23.1%. And Medicare Advantage administrative costs and profits accounted for about 4% of Medicare Advantage THC in 2023, down from 6% in 2022. We can move on to the next slide. And so here we're going to focus in on payer by market level TME per member per year growth rates. And just for a little bit of context, OCA collected data in the commercial space for about 17 million Californians with commercial coverage in 2023. As you'll see here on the left, you have enrollment shares by payer. So Kaiser accounted for just over 41% of those covered lives, followed by Blue Shield of California at just under 16%, and then finally Anthem Blue Cross or Elevance at 14.3%. Together, those plans made up about 71% of the reported commercial enrollment. And so, as previously stated, total commercial TME per member per year was around $6,500 in 2023 and rose to just over $6,800 in 2023, an increase of $326 or 5.0%. And then when we look across payers, you can see that TME growth does range quite a bit, from a slight decrease of 0.2% to an increase of just under 20%. But overall, most payers saw growth rates between 4 and 6%. We can move on to the next slide, which will feature Medicare Advantage payers. And so here we can see in 2023, OCA collected data on about 2.6 million Californians enrolled in Medicare Advantage plans. Once again, Kaiser made up nearly half of the market at 48.5%, followed by United at just under 18% and SCAN at 9.4%. Together, those three plans represented about 76% of the reported Medicare Advantage enrollment. Once again, Medicare Advantage plans showed substantial variation in TME per member per year growth. So overall, Medicare Advantage TME PMPY increased by 3.6% from 2022 to 2023, but we do see ranging from decreases of 12% to increases of 11%. And then finally, to round out the payer level reporting, we can move on to the next slide. Finally, so Medi-Cal managed care. So here we see 4 payers, LA Care, Centene, Inland Empire, and Anthem, accounted for a little over 50% of total MCO enrollment. Medi-Cal managed care payers saw an average TME PMPY increase of 5.5% between 2022 and 2023. And once again, as was the case in the previous 2 markets, there is considerable variation in growth rates, with some experiencing increases of 15% or higher, while other plans saw substantial decreases. In the baseline report, we do note that some of this variation in TME growth may reflect statewide policy changes, including shifts in how DHCS administers covered benefits from one year to the next. And we can move on to the next slide where we'll dig in a bit to service category level variation. So OCA collected data on spending by service category for commercial and Medicare markets, and we're able to break out Medicare by Medicare Advantage and the Medicare fee-for-service line, though the Medicare fee-for-service market is limited to claims data only. And so this slide shows growth rates in TME per member per year. So we'll start with that first column, which highlights statewide TME per member per year increasing at 6.2% from 2022 to 2023. You can see retail pharmacy increasing by 12%, professional services increasing by 7.6%, and then capitation increasing by 7%. So those three markets have the highest growth rates among the reported service categories. In terms of dollar contributions to that statewide total, those again were retail pharmacy, capitation, and then also hospital outpatient services. We can move on to the next slide where we'll dig in a little bit to those market level categories of spending. So with respect to commercial, we've already noted that TME per member per year grew at 5%. And so that when we sort of seek to decompose that $326 increase from 2022 to 2023, retail pharmacy contributed $117 or 36% of that growth. And then hospital outpatient spending contributed $94 or about 29% of that growth. Looking at Medicare Advantage, again, we're going to focus on the non-duals in Medicare Advantage for the moment. So TME per member per year increased by 3.6% or $540. Retail pharmacy contributed $224 or 42% of that growth. And capitation contributed just over $200 or 37% of that growth. And then finally, Medicare fee-for-service data. Claim spending per member per year grew from about $18,900 to $20,300, an increase of just under $1,400 or 7.3%. And here again, retail pharmacy contributed $410 or 30% of that growth, and then professional services contributed $379 or about 28% of that growth. Next slide. So here we're going to focus on claims and capitation spending by region. So just for a little bit of background, the regional data OCA collects is limited to claims and capitation spending from data submission guide submitters, so primarily from the commercial MA, dual, and DSNP markets. And that spending is assigned to regions based on a member's address. So non-claims payments are going to be absent here because they're often lump sum payments to a provider of medical care and not necessarily attributed to a specific member and thus can't be attributed to a specific region. So these figures show both 2023 per member per year spending levels on the left alongside their respective growth rates from 2022 to 2023. So that's the map on the right. And the comparison illustrates that regions with the highest baseline spending aren't always those that have the fastest year-over-year growth rates. We think that highlights some of the importance of interpreting growth within the context of existing spending levels within the state. And so you can see per member per year spending tends to be higher in Northern California, as is consistent with other data sources OCA's reported in previous months, and generally lower in that Southern California region, though there were some select service planning areas within Los Angeles County that did have high spending in absolute terms. And then rounding us out here, we did post at the end of last week an accompanying baseline report data book. So that link should be active in the slides. It links to a spreadsheet that has the underlying summary statistics featured in the baseline report, along with some other supplementary information that may be of interest, in particular, demographically adjusted payer level TME growth. So we, in addition to reporting the unadjusted payer level TME growth rates in the baseline report, that data book companion will feature age and sex adjusted payer level TME growth rates. And whenever appropriate in that corresponding spreadsheet, we included the formulas used to derive both the per capita and the PMPY descriptive statistics featured in that baseline report. And with that, I think we can open it up for any questions folks may have.
David, go ahead.
Yeah, thank you. Very interesting. I'm curious, did you have a chance to look at the difference between commercial HMO and commercial PPO? And
we do not have the slide readily available, and I don't know that I'm in the position to screen share. But yes, there is a section of the baseline report that does feature comparisons of HMO and PPO. At the risk of, I could sort of do violence to reporting those statistics to you, but I think there are some nifty graphics and bar charts in the baseline report itself that that distinction in HMO and PPO growth rates as well as the underlying size.
I'm curious because the IHA has published a number of times analysis that's shown that the HMO, which is mostly capitation, has grown at a slower rate than the cost of PPO, which is mostly fee-for-service. Did you see the same dynamics?
Yeah, so
Great.
HMO and point-of-service plans grew at about 4.2%, and they had lower overall PMPYs. So in that sort of $61 to $6,400 PMPY, whereas the PPO EPO market grew at about 6.2%, but has higher absolute levels as well. So anywhere between 7,200 to I'm sorry. I think only you may have been able to hear me, David. I don't know how much of that I need to recap, but yes. So I think it corresponds and confirms your priors about higher absolute levels in the PPO space as well as higher growth rates in the PPO space.
Joan.
So starting off, amazing work to you and the team. This is incredible information to have to inform our work going forward, and really appreciate the thoughtful slides as well, summarizing the report, because it's a dense report to try to summarize. The one that really does stand out to me is that administrative costs and profits slide, and was wondering if you can add any color about obviously not specific plans, but any conversations that you had with the plans and the submitters as that information was unfolding for you. Because I can imagine that led to some questions on your end, especially given the difference between commercial and Medi-Cal versus the MA plans, and just how were you looking at that data, and give us a little bit more flavor.
Yeah, I could start off. So the data that we did, so the way, as CJ covered on the first slide for total medical expense submission, the data that they submitted or the data submission guide, they submitted to us. There's like 4 or 5 files, and then we did do previews with them to review the data to make sure we got it right. But we didn't review admin costs and profits. That was collected under a different source, which is the CSIO filings. So we didn't have any in-depth conversations about that. From what we do know about admin costs and profits is that they do vary year to year. I wouldn't imagine admin costs will probably be more or less stable, but or not subject to swings as much. But it's the profit portion that may be doing that. So yeah, we do hope to engage the Health Plan Association to further learn about the year-to-year volatility.
That's great, and would love that engagement to come back publicly, because I'm thinking about this somewhat with my state budget hat on, and that there's so much conversation right now about the increase in Medi-Cal spending. And so seeing so much of the increase in Medi-Cal spending represented here, not going to patients, is a really concerning flag for me as we're talking about cuts, as we're talking about pulling coverage away from people, and seeing this, and on the commercial side, seeing with every conversation about coverage getting more expensive, just being able to really understand what's going into this and pulling that into these conversations and into the conversations with the board going forward.
Yeah, with regard to Medi-Cal, yeah, that will also need to be some more conversations with DHCS. They do have a pretty in-depth process for the way they review rates, which will include the administrative costs and profits component as well. But at least from what we've heard is that kind of the new mandates placed on MCOs under CalAIM and other initiatives, like so some of that may be driving what you're seeing in that figure that we showed.
Thank you. Adam, Andrew, and Sumana.
Yeah, just sticking with the same slide here. I do wonder, that was the most shocking thing to me, was the disparity between the proportion, particularly between commercial and Medi-Cal managed care, 7% compared to 15%. I almost wonder if it's not comparing apples to apples, or on the commercial side, are they doing something to make it look like there's not as high admin costs? Are they outsourcing? Are they calling it something else to make it look like direct medical care? So, very interested in, further parsing that. And then, to your point, really in the context of our current and ongoing budgetary challenges, what that means, and, on the MCO side, and looking forward from an administrative point of view, what are you thinking about? And I'm thinking about this in terms of how we're going to shop this to the legislature, to our constituents and our stakeholders, how we're going to shop this report, what kind of recommendations, are you going to be making specific, not policy recommendations, but findings and gaps and concerns, specific to those buckets, moving forward, once we have, multiple years and trends, and once you're able to parse some of that out, if you'd be willing to share any specific, highest recommendations and biggest points to bring across as we, face this to the public.
Thank you. Andrew, and then Sumana.
Yeah, I just wanted to commend OCA staff for the work here and the collaborative nature with the plan. So I think I'm the only payer representative here, but it's been really a good working engagement with the health plan. So just thank you for all the work.
Sumana.
Sorry, back to the admin side. It seems that a lot of the private payers, the commercial probably is including a lot of third-party contractors, because we're just seeing this across the board. And I'm wondering about, it's not just the cost that represents within the plan, but also the additional cost and friction that puts on clinical care. This year, there's one company that simply sends, they have far too much access to information. They can send and put in front of me something that says, why don't you refill not for 90 for 3 months and 3 refills, but 104 refills? It's a cute idea that could save time, but imagine dozens of these coming in to doctors at, times that represent your after hours, documentation times. So this is one little example of the ways in which those costs are increasing, and the numbers of different vendors doing little pieces of the APM or other and purporting to improve efficiency for the company is a whole nother piece. On your slide 101, I was really curious. I thought somebody would question the 12% increase for Medicare fee-for-service, and I just wonder if you have any insight into what other represents there, which is such an outlier compared to the other plans. Thank you.
We unfortunately, so the Medicare fee-for-service data request is probably the least granular data source we obtain. So it's effectively basically just a spreadsheet with 2 rows of entries. And so there isn't a whole lot to be gleaned or a whole lot to decompose there. So we just basically get very summarized statewide enrollment or member months, and then some of those core service categories. So it was sort of one-way traffic. Here's sort of satisfied your data request, and that's kind of where we left it last fall. Though unfortunately, we don't have a ton of additional detail to share.
Thank you. That's curious. Yeah.
Carmen, and then David.
Yeah. Thank you to the staff for this really great report to have, and to for us to kind of base off future reporting on in terms of the year-to-year changes. I also had a question about the administrative costs and profits slide. So I think very, very similar to what Joan and Adam had asked, which is, I think it would be helpful to find out, what exactly are we talking about when we're talking about administrative costs and profits, or, at least a disaggregation of administrative costs and profits. I think one big question that I have is, is marketing part of this? Where maybe we could get at least some idea of what's the billing costs within administrative costs. So, just a lot of questions about what's included in the bucket of administrative costs, and, the comparison between the commercial plans and the public plans, and what's being used for and reported. So, yeah.
Thanks, Carmen. I'm no expert on the medical loss ratio rules. I'm sure there are others in the room who are. Yes, I'm looking at you, Joan. But there are very strict rules about what's included in admin costs and profits, and so we can certainly help share that. But we didn't create those rules, but we are relying on that, and there is a consistent standard. I don't know if there's anything else anyone wants to add.
All right, David?
So Hill Physicians is guilty of encouraging our physicians to do 100-day renewals instead of 90-day. I thought I'd just explain for everyone why we do that. So medication adherence is a big deal for some drugs, and in Medicare Advantage, CMS measures you on medication adherence. And if you have 365 days in a year and you have 90-day renewals, you need 5 renewals to make your medication adherence 5 failure points. If you do 100-day supply, you only need 4. So we do that, and we're trying to encourage our physicians to get away from 90 days to 100 days because it's better for medication adherence, and I think it reduces total cost of care. So we're guilty of creating some of this friction, not in Monterey because we're not there, but we do it, and I think it's a good thing to do, actually.
Oh, yeah, no, I totally agree that it's a good thing to do. It was maybe a bad example of third-party vendors who, instead of one overall program that says do this, you are actually getting one individual request for one patient's one drug over and over again. Can you see? So it's more about the workflow problem than it is the principle. And then these are all third-party vendors. So many more third-party vendors are putting their stuff in front of physicians in ways that you can't deal with efficiently, and is probably increasing costs. That was the point.
Additional discussion from the committee? Looking online, noting we've got a couple virtual committee members attending, seeing no hands raised at this point. I believe that concludes this agenda item. We will move to public comment. If you'd like to make public comment on this item, and also because this is the last item on the agenda for today, we can include general public comment in this period also. Go ahead.
Jenny Nguyen from the California Hospital Association, here to give a few reactions to the information from the baseline report, including issues that were overlooked in today's presentation. First, the 8.4% annual per capita growth calls into question the attainability of the statewide spending target. The 2022-23 period was characterized by the emergence from the worst pandemic in a century, making it anything but a normal 2-year period. Today also is an uncertain and unstable period, and OCA spending targets should reflect contemporary anticipated future conditions. This would make California look more like Rhode Island, whose progress was highlighted today, that look at current, not simply historical economic trends when setting and actually revising their spending targets. Second, we thank OCA for highlighting the enormous and concerning growth of health plans' admin costs and profits. In the commercial Metro and Medi-Cal markets, this amounts to more than 25% growth in spending not related to direct service delivery. And it means that 25 cents of every additional premium dollar spent by Californians supported payers' profits rather than direct care. We second questions from Ian Lewis at last week's board meeting for further inquiry and scrutiny on this matter. Thank you.
Thank you. We don't see any raised hands from members of the public who are joining us virtually. If you would like to speak, please do raise your hand. Also inviting others in the room to come up to the podium. Please go ahead.
I'm back, thank you. Yeah, it was a wonderful slide deck. I just want to comment on the hard work you put into that. One thing I was going to mention on that last comment on management fees and administration fees, typically it can be as high as 30 to 40%. Probably all know that. I just put the slide deck into chat, the expert, and it looks like it might be excluding MSO fees, TPA fees, broker commissions, insurance profit margins, PBM spread, and care coordination tech platforms. So that's something to consider perhaps when you're looking at cost and data related to care delivery from the IT perspective. And then the other thing that is coming up is quality measure software programming, which is coming in to kind of improve the quality measures and scoring on that. But it was wonderful information, so thanks for sharing.
Thank you. If there's anyone in the room who'd like to make public comment, we invite you to come up to the podium. Of the 52 members of the public still attending right now, there are no raised hands. Okay, so I'll just look to members of staff. Otherwise, we'll go ahead and adjourn the meeting. All right, thank you all. That concludes our general public comment period as well as the meeting, which is adjourned. Thank you.